Pregnancy is the only thing you go to a hospital when you're not sick. Oh, you're going to thrive if you go to Kaiser and all these sorts of things. They don't give a about the individual patient. I mean, I can say this openly because I spent 28 years working in the hospital system. Have our children gotten healthier because of vaccines? Have our children gotten healthier because of the food they eat? Has 5G made our children healthier? Has glyphosate made our children healthier? Has geoengineering and chemtrails made any of us healthier? No. Once you get somebody who's chronically ill, Big Pharma has a customer for life. But then the hospitals figured it out. They figured out that this is a shitty business model. What we need to do is we need to control the patient lives. We need to have the patients, and then we need to hire the doctors. These same doctors who tell you not to eat sushi while you're pregnant will tell you that at 28 weeks, you should get 3 vaccines with 5 antigens in them, and another one at 34 weeks. Dosing of medicine for babies is based on weight. Antibiotics, anti-seizure medication, it's all calculated based on fetal weight.
But not
vaccines. Baby weighs 5 pounds, baby weighs 10 pounds, gets the same vaccine. You know, we've sterilized birth from the family, just like we've basically sterilized death too. 100 years ago, Apollo, people were born and died in their own home, their own bedroom. People saw Granny grow old and die. They stood by her, held her hand, kissed her. You know, COVID was the worst. We saw these people die alone. Right. And they saw their siblings being born. They saw mom do it. And mom did it because she saw her mom do it.
Life cycle.
Right.
A short announcement before we start. This specific episode with Dr. Stuart Fischbein, which is a legend here in the United States of America, is going to boil your blood because of the information you're about to be exposed to. Be sure that YouTube is going to demonetize this video. I believe YouTube is going to take this video down as soon as possible. So if you're still seeing this video, if you're still watching, please like this video right now, leave a comment below, subscribe to my channel if you haven't done that already, and please share it with as many friends and peers and loved ones as you can. Guys, we don't have any sponsors, so the best way for you to help us making this kind of videos is just to subscribe to my channel, leave a comment below, like this video, and share with all your friends and peers. And if you want to become a member of our community, the link is going to be down below. And now, without any further ado, let's get back to the podcast with the legendary obstetrician, Dr. Stuart Fischbein. Stuart James Fischbein, MD, is a community-based obstetrician and an associate of the American College of Obstetrics and Gynecology, published author. After completing his residency at Cedars-Sinai Medical Center in Los Angeles, Dr. Stu spent 28 years assisting women with hospital birthing and, for the next 12 plus years, was a homebirth obstetrician who worked directly with midwives assisting local Southern California families. Since retiring from attending homebirth in late 2022, Dr. Stu has turned his focus to traveling around the world as a lecturer and advocate for reteaching breech and twin birth skills, respecting for the normalcy of birth and honoring informed consent. He hosts the weekly Birthing Instincts podcast with co-host Bliss Young, and together they offer hope, reassurance, and safe, honest, evidence-supported choices for those women who understand pregnancy is a normal bodily function not to be feared. Welcome to the show.
Thank you, Apollo. It's an honor. You know what? It's an honor to be here to speak to an audience that probably has never heard something like what we'll be talking about.
Yes,
and for me to expand the ability to reach other people. I'm very grateful for you to have me on your show.
So let's start with before the pregnancy. Let's say a couple, they want to become pregnant, they want to have a child. Is there anything that a woman should do prior to get pregnant?
Yes.
What is it?
First of all, some of these things are fairly obvious. You want to be in the best physical shape you can. So you want to be eating healthy, and we're learning a lot more now in the last couple of years about what eating healthy means, because you've got to avoid the processed food, the GMO, all the things that we thought were normal are not normal. You should try to eat organic. You should try to eat a well-balanced diet. You should try to be joyous and happy. You should be physically fit. You should, if you have some medical issues, you should try to get those resolved beforehand. Like if your thyroid is a little out of whack, or if you're a little overweight, those sort of things. You want to try to get those in the best condition possible, because fertility is related to how your system works. Your body knows that to carry a baby is an ordeal sometimes, and therefore the body knows when it's not a good idea to be pregnant. And so someone will skip their periods when they're unhealthy. They'll have hormonal irregularities. You want to get that all cleared up. There's a movement now with something called restorative reproductive medicine and NAPRO technology, outside my expertise, but I've been talking to them. We've had a couple of them on our podcast, and what they say is it's very commonsensical. It's kind of what our ancestors knew and we've forgotten, is to just live a healthy life, get outside, get the sunlight, put your feet in the grass, meditate, turn off the things that stress you, lower your stress level. Cortisol is a detrimental hormone for conception and for life in general. So those things are very important to do for yourself.
Let's say a woman is unhealthy, for instance, McDonald's, fast food, etc. For how long before she gets pregnant, she should switch to healthy eating?
Okay, that's a really good question. And I have this thing that I call my Dr. Stu's exact number rule. And anytime someone tells you an exact number of something, like, oh, you should wait 3 months or you should wait 6 months. Can I swear on your podcast?
Yes, you can.
Okay, they're full of shit. Right?
This is not swearing.
Because that is an algorithmic thing that they say, but it does. We need to individualize our care. The beauty of the model of care that I learned after spending decades in the medicalized model was through the traditional midwives, was that you individualize your care, and you still can do that in that model. Whereas in the medical model, everything's sort of run on an algorithm. But when they tell you you have to wait 6 months, or you have to, if you're over 35, or you 42 weeks is beyond a problem, or 24 hours of ruptured membranes, or 18 months from a previous C-section. These are made up numbers. So I don't want to be too specific when you ask me, how long should you be getting your body healthy? Your body will know it's healthy when your vital signs are restored, when your menstrual periods are regular, when you sleep well through the night, when you have energy during the day. And for some women, that could take a month. For others, it could take longer.
Is there a correlation between an unhealthy woman with disrupted hormonal system and, let's say, not fit at all? Is there a correlation between unhealthy woman giving birth to an unhealthy child with some kind of a disease or problems health-wise?
Well, that's a really good question. First of all, conception depends on being healthy generally. We all know unhealthy people that conceive, so that's nothing is hard, fast rules. You can't have that. That goes against common sense, because we all know somebody who, how did they get pregnant?
Yeah, like 300 pounds and she's pregnant.
Yeah, so we all know that that's the case. But there is something called epigenetics, and epigenetics is sort of, we all have chromosomes and genes. But just because you have the same half the chromosomes from your father and half from your mother doesn't mean that they're going to be expressed in the same way. You may have a sibling that has completely different bodily makeup than you do, and yet they shouldn't. So something changes. And that's why one of the things we talked about avoiding was stress. Because when you are stressed, you're secreting these hormones that are stressed that cross the placenta, and they begin to affect the baby as those little neurons and little cells are developing at incredible rate, by the way. If they're bathed in, say, happiness, dopamine, oxytocin, joyous hormones, they may express themselves differently than if they're bathed in stressful hormones. If you're in a time of famine or a place of war or whatever else, there may be that may be expressed down the road. It's hard to study something like that, Apollo. It's really hard to know, but it's commonsensical to think that in nature, if you look outside the human species and you look at all other mammals, all right, it is survival of the fittest. Mammals know when it's safe to get pregnant. If there's a forest fire, if there's a famine, if there's a drought, then those mammals will shut down their ovulatory cycle and they will not get pregnant until it's ideal situation for them to get pregnant. Because what nature wants is you to do it at the right time to ensure the best chance of survival of your offspring. Ultimately, that's the purpose for all of us on the planet, really, is to pass on our genes and our knowledge and our wisdom into the next generation. So, yeah, and when we're talking about all this, by the way, I've been spending this whole time talking about women. The same thing occurs for your partner.
That's my next question, yeah.
Okay, go ahead.
So what should men do before he conceives?
Same thing. They should try to get very healthy. They should get off substance abuse, alcohol, marijuana. This goes for the woman too, obviously.
Yeah.
Stop smoking pot, stop smoking cigarettes, eat healthy food.
Is there a correlation once again between a person that smokes weed or just cigarettes and unhealthy baby?
Well, that's a good question, because ultimately the man is contributing sperm. So you're basically saying, are they giving you unhealthy sperm? Mm-hmm. And yeah, the answer is that sperm counts and sperm motility and sperm morphology are affected by environmental forces. So yeah, the original question was, what can you do to optimize your ability to get pregnant? And so, listen, we've seen people who are drug addicts, as you said, people with 300 pounds, they can get pregnant. It's just not ideal. So the ideal situation is to try to be as healthy as possible, and whatever that means in your environment. But one of them is really limiting stress, getting plenty of sleep, getting exercise, getting outside, breathing good air, eating good food. Those are just normal things. By the way, these are things we should all be doing whether we're trying to get pregnant or not. We should all be trying. We should all be trying to eat and live a healthier life.
You know, I would say the thing is that it's not about just having the ability to conceive, but having the ability to give birth to a healthy child. This is even more important, right? Even if you can't conceive, yeah, that's a problem, right? But you try and try and try. You see doctors, etc. But the moment that you conceive, you just pray and do everything that you can, everything that is in your power to give birth to a healthy child without any health problems.
Yeah, it's the strongest desire that a family can have, is obviously you want the best possible outcome for your offspring, for your child. So why not do these things? These are not complicated things to do that we just talked about. Eating healthier, getting outside, doing these things, lowering your stress, feeling love, having a strong relationship with your partner, secreting dopamine and oxytocin. First of all, they make you feel good. I mean, why is it that we eat a candy bar? Or why is it that we watch reruns of Seinfeld or whatever? Because they make us feel good. And so there's something to that. Ultimately, I just think that you can only bring people to water or lead them to water. You can't make them drink. I think most people know that it's better to be healthy than unhealthy. But we're a flawed species. We do things that aren't necessarily good for us. Right.
What would you say are the 3, 4, 5, maybe 2 major mistakes that women do prior to they get pregnant? Is there anything that they do that is horrendous for their future child?
Oh, that's a really tough one. I mean, not specifically. I mean, everything that I've mentioned before.
Let's say she's obese, like 300 pounds, and she's like, maybe I should use Ozempic right now. That would be horrendous?
That would be a mistake. Right. I think that's a whole other topic. And again, I'm not an expert in it, but I am an expert in history. And medical history is filled with what's called stage 1 thinking.
What is that?
Okay. Stage 1 thinking is doing something or creating something or recommending something because it sounds good or it feels good or it gives you an immediate result without ever asking the follow-up question, which is, if we do this, then what happens? Right. Ozempic is a perfect example, and following on the footsteps of things like thalidomide and diethylstilbestrol. Do you know what those are?
No.
Okay. Thalidomide was a drug that was used in the 1950s in England. I believe it was the 50s in England for women with hyperemesis, which is where women are nauseous during their pregnancy. They thought, let's give this drug and see what, and because it works for hyperemesis, but they never studied it. And what it did, it was called limb reduction defects in their fetuses. So babies were born with very short limbs or absent limbs, and it was horrible. And if people look at it, you can look up the history of thalidomide. So now, don't you think they should have tested it first before they made it for widespread use?
But how do you test it? You're having a test
Animals.
group? Animals?
Animal testing. Or,
yeah, but animals and humans are different, right?
Well, not necessarily. Not necessarily.
You know, there are going to appear a few...
I mean, we are different, but not necessarily for testing purposes.
People would say, how can you do that to poor animals?
Well, that's an interesting way to put it, all right? So how would you introduce a new drug if you're afraid to test it on animals? Okay,
there's no way.
You could get volunteers, but you should do a randomized controlled trial or randomized double-blind controlled trial. That's how medicine should be done. But thalidomide is just one example. Diethylstilbestrol was given for women who had threatened miscarriages, and this was done worldwide. And what it did was it caused abnormal development of the fetus's female organs, so that when they grew up, they had problems. They had abnormal uteruses, they had abnormal cervixes, they were at risk for cervical.
You mean size-wise? Abnormal?
Yeah, short, misshapen, abnormal fallopian tubes, all kinds of problems on a drug that was given without testing. Then you have Vioxx. Vioxx was a drug that was given for inflammatory issues and pain and that sort of thing. Turns out it caused cardiac heart attacks.
Women or fetuses?
No, in everybody who took it. I'm getting back on the topic of saying this, that drugs are introduced and procedures are introduced because either they think they're going to do good, but they've never been proven to do good, and always it turns out that someone made a lot of money from doing it.
Okay.
So behind all these things is money. Another good example that's non-medical of stage 1 thinking is something that happens in pregnancy, and your listeners may have heard of this. It's called continuous fetal monitoring. Continuous fetal monitoring are little belts that you wear when you're in labor. I don't know if your wife wore them when she was in labor.
No, but I know what it is.
All right. So they wear them. These were put into place without any evidence that it was going to do any good. They just thought, well, we're going to see the heart rate. We're going to catch babies in trouble, and we're going to prevent cerebral palsy and interpartum stillbirth. After more than 50 years, Apollo, of using this, it's done neither. Not only is there no evidence of benefit, there's evidence of non-benefit from this monitoring, because the C-section rate is directly related to this, has gone up 600% in the United States and far more in many European countries. There are countries like Armenia, South Africa, Brazil, that have C-section rates above 70%. And this is felt to be normal. This is felt like, who in their right mind would think that 7 out of 10 women can't deliver their baby as nature designed? And yet the medical cartel just keeps rolling along, just keeps going along. So Ozempic, your example of Ozempic, I would bet my fortune that 5-10 years from now, there are going to be all kinds of complications from people that took Ozempic. And I wish that they would not take it. Right.
What are your thoughts on ultrasound?
Can I back up for 1 second?
Sure.
Because one other thing that when you talked about a woman preparing for child before she's pregnant, and I didn't want to get away from that too much. The other thing is to check out your community. So when you're thinking about buying a house, right, you do diligent work. You investigate your community. Where's the schools? What are the hospitals like? Where's the nearest Costco or Walmart or whatever? You check that out. What are the property taxes? Who are my neighbors? You do a lot of hard work to figure that out. When you move to a community, before you get pregnant, you want to check out your community, right? What's the hospital like there? Does the hospital support breech delivery or VBAC delivery? What's the C-section rate of my hospital? And then do the same thing with your practitioner, whether it be an obstetrician or a midwife. Go and interview them before you're pregnant and ask them the questions. Like, do you know breech delivery? What's your thought about vaginal birth after cesarean delivery? What happens if I go overdue? Do you make me come to the hospital if I break my bag of waters and I'm not yet in labor? All these things. Find out ahead of time so that you're not stuck in a hamster wheel of now it's too late. Now I'm 38 weeks. And also, the thing that you can do before you even get pregnant is check out your community for advocates. Find out who the doulas might be. Find out who the patient advocates are. Find out the midwives. Check them out. Be vigilant. Put as much effort into your pregnancy as you would to buying a house, or the analogy we use all the time is your wedding. I mean, the two most important events in a woman's life probably are her wedding day and the birth of her children. They're the things that she remembers most of her life. For your wedding, you plan everything. You plan the venue, you plan the invitations, you pick out the guest list, you taste the cake, you pick out the color of the napkins, for God's sakes. You plan everything. For your birth, you say, oh, I live in this community. I've been going to this same doctor who's been doing my pap smear for 10 years. She's great. I'll just go to her. And my insurance says I have to go to this institution, so I'll do that. And you don't, and you abdicate your responsibility for that. You should put as much effort into your birth as you do for your wedding. And by the way, if you have to spend money on your birth, then spend money on your birth. Do not just say, I have to go here because my insurance covers it, or my Medi-Cal, I have to go where the Medi-Cal pays. Make an investment. Start saving money when you're a young woman in a health savings account, and save it for your birth so that you can choose to go out of network if you have to. So you can choose the best practitioner in your community. You know, the analogy that is very famous in our community is, as I was saying, the wedding analogy is what if you had wedding insurance? And what if from the time you're 20 years old, you paid $20 a month, and when you got 30 and you were getting married, your wedding was covered by your insurance company?
And they tell you
but they tell you where you can get married, and they tell you what you can wear, and you can have the fish but not the chicken, and they can tell you, and they invite people to your wedding you don't like. No one would do that. They invite strangers to your wedding to stand there and stare at you while you're getting married. No one would do that, right? Yet for your birth, which is probably as or more important than your wedding with the birth of your children, because it sticks with you all your life. On your deathbed, you'll remember the birth of your children. You'll see the faces of your children. We just abdicate that. So what I would do, the answer to the end of your first question was all the healthy things we talked about, but also plan ahead. Look at options.
But it sounds wild. You have to save for when you're going to give birth, you have to save
You save for
money
vacation.
Yeah. And it's like 2 to 3 times in your lifetime.
And we've been well, some people more, but we've been counseled, or not counseled, we've been coerced into believing that birth is a medical problem, therefore my insurance should cover it.
Well, it covers, but not the way you like.
But it shouldn't. But in some ways, it's not right. Insurance should cover the problems. I mean, no other insurance do you expect to pay for normal things. You have a car insurance, they don't pay for an oil change.
Right.
You have homeowners insurance, they don't pay to paint your house. Right. Not routinely. You do it because it's good for your house or it's good for your car. So spend a little bit of money on this and stop relying on these companies that do not have your best interest at heart. People are, they make very nice commercials, propaganda commercials that tell you, oh, you're going to thrive if you go to Kaiser and all these sorts of things. They don't give a fuck about the individual patient. They don't. Their bottom line is to keep their bottom line. So their ethical responsibility, their fiduciary duty is to keep their doors open. And if that means doing more C-sections because they get paid more money, then that's what they do. Now, some people look at that and say, that's horrible. You're saying they're horrible. No, that is that is the fiduciary responsibility of the chief financial officer of the hospital. It's not to the individual patient. It's not even to the employees of the hospital. It's to keep the hospital viable.
Because it's a business.
They're obligated to their shareholders or their stock or their board of directors. That's who they're obligated to. So they're like the C-section rate we talked about, being 30-some% in the United States. 50 years ago, it was 5%.
50?
50. 1970s, it was 5%. And we've had a 600% increase in the C-section rate with no improvement in outcomes. As a matter of fact, our outcomes have gotten worse. All right. We have more babies going to NICUs now than we did then. We have more mothers who complain of postpartum depression or birth trauma than we did then. We have no decrease in the rate of neonatal death, and we have a slight increase in the rate of maternal morbidity. Right? All for naught. We've done all these interventions, all this continuous fetal monitoring, all these ultrasounds, all these inductions, all this color flow Doppler, all these C-sections, all these medications, and our outcomes are not better. This
Makes
is
no sense.
This is, yeah. Well, there you go. You've summarized my life in one sentence.
If you have a business and you invest in marketing, you hire some people and you do the same numbers, it doesn't make any sense.
No, and how long do those people stay on your staff? You fire them.
You fire them.
Right. We should be firing the people that have been running the medical system and obstetrics for the last 50 years because
but you can't do it. You can't fire them because you can't vote for them.
No, you can't fire them because it's the old perversion of the golden rule. You know the golden rule: do unto others as you'd have them do unto you. You've heard that?
No.
Oh, you've never heard that?
No.
Oh, that's like we were taught that as kids here in America. That's the golden rule. But the perverted golden rule is
what's the golden rule once again?
Do unto others as you'd have them do unto you. So be nice to people, basically. But the perverted golden rule is them that has the gold makes the rules. So it's monolithic. But how you judge a system should be on outcomes. It shouldn't be on intentions.
Correct.
Intentions don't mean anything. Intentions are useless if the outcomes are poor. Somebody could have bad intentions and have good outcomes. It's like, that's okay. But having good intentions and bad outcomes, it's time to make a change. And the system has proven to us, the obstetrical system in this country, the maternity care system in this country has failed miserably. We have, not only are mothers getting more trauma and more C-section, things like that, but we have never had a time where we've had our children be unhealthier than we have now. And there are many factors for that. But your immune health begins in the womb. And if we don't take care of ourselves while we're pregnant or before we're pregnant, we're not helping our babies optimize their immune health. And when we deliver a baby by cesarean section and mother's gotten antibiotics and the baby goes to the nursery and there's no delayed cord clamping and no skin to skin, the baby is colonized with the wrong bacteria, and 80% of your immune system probably is developed from your gut flora, your gut microbial. You've probably interviewed people.
Brain.
What's that?
The second brain.
Yeah. Is it? Is that what they call it?
The guts? Yeah.
Yeah. Yeah. And if it's colonized with the wrong bacteria, you are going to have a hard time ever correcting that. And we know that babies born by cesarean section, especially elective schedule without labor cesarean section, do have higher rates of childhood asthma, eczema, autoimmune disorders, adult onset diabetes. We know that these things can, and they're all related to the immune process.
So why do women do C-section? It's more easier, faster, less pain?
Well, that's a broad question. Why do women do C-section? Most of them do it because they're convinced that they need it by the people who don't really know what they're doing. Physicians will coerce you subtly or overtly into having a C-section. They will use things against you like, you want a healthy baby, don't you?
What does it have in common with C-section? A healthy baby.
Well, what they're concerned about is the baby. They're going to find reasons to force a woman to be induced or to have a C-section, because in the medicalized birth model, the goal is to get a live baby in the bassinet. And how the baby gets in the bassinet and what happens to that baby, that mom, and that mom's future babies is not the concern of that immediate sector. Mm-hmm. So C-sections are way, way overdone. Like I said, 50 years ago, 5%, same outcomes. Now, 30-some% in my country, 70% in Armenia. South Africa is closing in on 80%.
80%?
That's what my friends in South Africa say. So that's crazy. So you know that there are unnecessary C-sections. Now, the World Health Organization, which I will probably not mention again on this podcast, but because I have very little regard for them, but they do make a statement that they say the C-section rate in Western countries should be somewhere between 10 and 15%.
Oh, wow.
Okay. And that's generous because it was 5%. So let's just say they're right. And let's say it should be 15%. And let's say in the United States it's 30%, even though it's higher, because it makes for easy math. We have about 4 million babies born every year in our country. Right? If 30% are having a C-section, that's 1.2 million C-sections. If I'm doing my math correctly. Right.
Yeah.
Okay. If it should be 15%, that means half of those C-sections are unnecessary, which means there's 600,000 American women every year undergoing surgery they didn't need. Now, if there were 600,000 unnecessary knee surgeries or mastectomies or tonsillectomies, everybody would be upset about that, including the insurance companies who are paying for that. Yet 600,000 unnecessary cesarean sections and you hear nothing. It's crickets. You hear nothing. Nobody's complaining. So that's horrible because you're putting 600,000 women at unnecessary risk, not only for that pregnancy, but for themselves and then for all their future pregnancies because now they have the scarred uterus thing.
Mm-hmm.
But here's where the term cognitive dissonance sets in. I'm not sure people understand what that means. They can look it up a little bit. But simply put, cognitive dissonance, cognitions are thoughts. Mm-hmm. Dissonances are contrary thoughts. So we
like
don't
an error in the system. It's like,
yeah, we don't like that. A simple example would be I'm on a diet, but I really want some ice cream. Mm. So your brain is going nuts because so you have to figure out a way to rationalize why it's okay to have ice cream. And so you end up rationalizing, say, oh, I'll skip breakfast tomorrow and I'll have my ice cream today. And then you don't skip breakfast tomorrow, but it doesn't really matter. But this is one of the examples when I teach my course that I talk about cognitive dissonance, is if you believe that the C-section rate should be 15%, then you have to believe that there's 600,000 unnecessary C-sections being done every year in the United States, which is awful. Ask yourself the question, who's doing them? Who's doing the unnecessary cesarean sections? Because if you ask any obstetrician, have you done an unnecessary cesarean section, they're going to say no. Yet half of cesarean sections are unnecessary. Mm. That's insane. So they have to justify it by saying that they're doing necessary ones, but that guy over there, they're doing the unnecessary ones. But what's that guy over there saying?
Pointing fingers at each other.
Yeah. And nobody takes responsibility for the fact that 600,000 American women every year are having unnecessary surgery, and then the subsequent problems that occur from that. So when you asked about why are women having C-sections and stuff, sometimes they're necessary and they're life-saving. And this is a real problem because what I'd love to see is the hospitals take care of patients who need them and for people who don't need hospital care to not be in the hospital because their outcomes will be better. But organized medicine doesn't believe that because organized medicine is an industrial lobby and they want to keep control and power and money to themselves. And if suddenly 50% of women or 60% of women said we're not going to the hospital anymore, hospitals would go under. Mm-hmm. And the American College of OB/GYN would lose control.
You'd be the enemy number one.
What's that?
You'd be the enemy number one.
Yeah, I'm too small right now to be, noticed in that area. But yes, this is why you look at what RFK Jr. is doing and why he is enemy number one to big pharma and big hospitals and big food and other organizations. They're doing everything they can to undermine what he's doing because what he's doing makes logical sense. It's healthy. It's proven because of the outcomes that we've seen are worse. Have our children gotten healthier because of vaccines? Have our children gotten healthier because of the food they eat? Has 5G made our children healthier? Has glyphosate made our children healthier? Has geoengineering and chemtrails made any of us healthier? No. And yet they go on anyway because somebody's making a fortune from it. And then once you get somebody who's chronically ill, Big Pharma has a customer for life.
Correct.
I mean, you watch. You talked about Ozempic. People are on Ozempic. They're going to start having side effects from Ozempic. What are they going to do for the side effects from Ozempic?
Another pill.
They're going to take another pharmaceutical product. Correct. What a great scam.
They fall for it, and people fall for it.
Well, because they've been indoctrinated to trust their doctor. When I grew up,
How can a doctor prescribe Ozempic? They should prescribe going out, working out, going to see the sun, grounding, eating
can't-
right.
yeah, I can't speak for any individual doctor. There's money obviously in it. Probably there's a profit motive. There's probably bonuses that are paid. It's also a fast and easy way to get someone out of your office and turn it over so that you can see volume. Part of the problem is that insurance companies reimburse doctors very poorly for any individual care. So a doctor who has a set overhead, which is expensive to run an office and have a staff and have malpractice insurance and you know all the tech that they have to have and all that thing, they need to do volume. And if you spend 45 minutes with one patient, you're going to lose money. So you need to see 6, 8, 9 patients an hour. You know, if somebody comes who's morbidly obese, is it easier to just hand them a prescription for Ozempic, or is it easier to talk to them for 45 minutes about changing their lifestyle and then calling them up next week and having another conversation? How's it going? They don't do that. It's just
But how about the oath that they gave when they became doctors?
oath.
Nobody believes in that anymore?
I think the individual doctors might, but the individual doctors no longer run the show. That's another thing that's happened to medicine. If this is starting to sound overwhelming to people that are listening, it should, because it's all intertwined. But doctors used to be individual practitioners, private practitioners, and hospitals used to court doctors to bring their patients to them. But then the hospitals figured it out. They figured out that this is a shitty business model. What we need to do is we need to control the patient lives. We need to have the patients, and then we need to hire the doctors. And so in the 80s and 90s in my country, managed care came in and began to take over the medical world. And what they did was they found ways to get patients on their payroll, like you're a member of an HMO. And then the HMO began hiring doctors. And so doctors went from being independent practitioners who could make decisions and individualize their care to being salaried employees working a shift with a boss who's telling them how to practice. You need to see 8 patients an hour. You cannot let somebody go past 41 weeks. We don't support VBAC in our system, so you need to skew your counseling to make sure that you scare that woman out of trying to have a vaginal birth after a cesarean, because we don't allow it. So doctors who were good people at one point have to make a decision. Do I keep my ethics and lose my job? Or do I keep my job and lose my ethics?
How to fix it?
That's a good question. First, one of the things that we could do to fix it would be to change the way reimbursement is issued. Because you're going to have to fix it through the system that exists right now. You're not going to suddenly, you know, Elon Musk or Bill Gates or some billionaire isn't suddenly going to say, this hospital system sucks, we're starting a new one. It's just not, it's not going to happen. So one of the ways that you could influence people, and that's the way it's always been done, you know, they used to say basic economics 101. If you tax something, you get less of it. If you subsidize it, you get more of it, right?
Mm-hmm.
Basic, you remember that stuff? So if you subsidize something like you pay more for a cesarean, you get more cesareans. If you pay more for a doctor to give 80% of his children vaccines, you're going to get that doctor using coercion and getting more patients in their practice vaccinated. And those that don't want to be vaccinated, they're going to kick them out of their practice so they can up their percentage. This is what incentives do. This is what money does to all of us.
So basically, their own KPIs are set. If the KPI is going to be
what's a KPI? I don't know that.
The result-driven, merit-driven results. Let's say not to get 90% of children vaccinated, but to get 90% of children healthy, and these are the metrics that we measure their health. That should do the thing. But if they pay for you, if you get your 9 out of 10 patients vaccinated, of course you're going to vaccinate them.
Right.
But if you set the standard, 9 of your 10 patients have to be healthy, at least children, because you can get a healthy child very easily.
Right.
That would change everything.
Bingo. This is exactly what I was going to lead on with. So in my profession, obstetrics, it takes more skill and more time to do a vaginal delivery. Yet the hospital gets paid 2.5 times as much for a cesarean as it does for a vaginal delivery. One thing that you could do tomorrow is to turn that around, is for insurance companies to pay hospitals twice as much as they're paying them now for a vaginal delivery and half as much as they're paying them now for a cesarean. Now, if cesareans are really necessary, hospitals are going to have to bite the bullet. But I can tell you that suddenly VBAC and breech delivery and twin vaginal delivery are going to become very popular. Okay, they will, because there's plenty of oral literature that supports those, but they ignore that because economically, expediency, medical, what they believe medical legal liability, all tend toward doing a C-section. Why would any doctor offer a woman a breech vaginal delivery in today's world? Because it requires more time, more skill, what is perceived as more liability for less pay.
Makes no sense.
Right. Well, what only makes sense is if they are keeping to their ethical code of satisfying the needs of their clients, their individual.
Yeah, but if the woman's need is to give birth as quickly as possible and as
Well, who says that?
painless as possible, women. Don't you think all women want to give birth with as little pain as possible?
I think that the whole idea of pain needs to be rethought. Okay. Should we go there?
Yes, let's go there.
Okay, let's go there. All right. So why is, first of all, you have to ask a question. Why is labor painful? Why did God or nature design labor to be painful?
Genesis 2, the fall. God said you're
Well,
gonna
okay. So if you believe in the biblical view, then that's why. And I get that. But if you believe more that there's a natural reason for it, what would that reason possibly be?
No idea.
I do.
Please.
Okay. So when you have a surge, you can call it a contraction, a surge, a pain, whatever word you want to use, a wave. Wave sounds nicer, surge sounds nicer than pain. But it comes on and it lasts 30 to 60 seconds, and then it goes away, and then it comes on again, and it's very uncomfortable for the woman. When you experience pain, you and I, okay, we put out neurotransmitters. Our body tries to respond to pain by doing several things. One of them puts out endorphins, which are your body's own opiates. It puts out adrenaline, which helps you compensate for that. It might put out cortisol, which is a stress hormone.
Mm-hmm.
Okay, and then the contractions are caused by something called oxytocin, which is more than just causing contractions. It's also your love and bonding hormone. So these 4 hormones probably are secreted every time you have a wave, right? Also, you have something called, what I was taught was called the gate theory of pain. That might be the wrong title, but classically, I'm going to tie this in right now. When you have pain, you automatically do something. So if I were to ask you, if you banged your elbow on something, what's the first thing that you would do?
Scratch it, maybe.
That's the second thing you would do. The first thing you would do is go, fuck. Right. You'd probably swear.
Yeah.
And then you'd rub your elbow. Mm-hmm. So here's the question. Same thing with you burn your finger. What's the first thing you do with you burn your finger besides swear? Then you blow on it, or you suck on it, or you run it under cold water. That's not preventing the burn. That's not making the burn less. It makes it feel better.
Correct.
So let's ask yourself, so I can tie this in with the other thing, why does it make you feel better? It makes you feel better because when you bang your elbow, on the opposite side of your brain, there's a little mapping of your body called the homunculus, and there's a little spot that's going, that the nerves are firing, going ouch, 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 ouch. The minute you start to rub your whole elbow, all the nerves around that begin to fire, and your body can no longer pick out the specific spot because all the nerve endings are firing and all the neurotransmitters are depleting, and so your body can't fit. That's why. If you bang your knee, you rub your knee. It just feels better. If you got an aching muscle, you rub you rub your body.
Correct.
All right. This is nature's way of doing that. So when a woman is in labor and she's able to freely move about, and you watch her and leave her alone, she is going to move, she is going to rock, She's going to sit on a ball. She's going to ask someone to squeeze her hips. She's going to have somebody ask them to use a rebozo, which is like a scarf, to shimmy them. She's going to get in water. She's going to love having that shower beating down on her back. She's going to like to be in the tub. She's going to do things to help with the pain. She might have a contraction coming. The baby's pushing on part of her pelvis. You just watch them. They'll lift their leg. They'll put the leg on the side of the bed. They're responding to their body. Okay, now, take the hospital model.
You just lay.
All right. Before I even get there, let me say one more thing. For those of you who've never been to a home birth, I strongly suggest that you try, especially you obstetricians out there and medical practitioners. If you have access to a home birth midwife, ask her kindly if she can ask her client if it's okay if you come sit in the corner and watch. You're not putting yourself in any liability. You're not doing anything medical. You're just Uncle Billy or Aunt Susie in the corner, and you're just watching. And if you come to a house with someone in labor at home, I can tell you with almost 100% certainty you'll never find them laying in bed. Mm-hmm. They might be on the bed, on all fours. They might be leaning against the bed. They might be sitting on the toilet. They might be in the shower. They might be in the kitchen. They might be on the floor. But they're never laying in bed, just laying in bed. Now, what happens when you go to the hospital?
You lay in the bed.
The first thing they do is they put you in a bed. The bed is the center of a labor room. If you've ever been in a labor room in a hospital, the bed is in the center. Not the tub, not a ball, not something to hang from the ceiling. It's the center of the bed. It's the center of it, because that's the mentality of the hospital. Pregnancy is an illness. You have to change into a hospital gown and you have to get in bed. So we can put belts on you, so we can take your vital signs, so we can start an IV. So you're in bed. Now, how easy is it for you to move in the bed and do the things that we just talked about that a pregnant woman would like to do when you're in bed, having to wear the belts, and they have to watch the baby's heartbeat? Of course, we've already talked about the fact that continuous fetal monitoring has done nothing to improve outcomes, but they have to do it because it's a liability issue, they think. And if you move, then the heart rate disappears because you've moved. And then they rush into the room and they say, oh, we got to readjust the belts and stuff. So they want you to lay straight in bed. So you're having these surges. You're putting out these hormones, all right? And you can't deal with pain on your own, all right? Now I'll stop for a second and think. So when you put out these hormones, when you're having this discomfort, those things like endorphins, cortisol, the things I talked about, some of those, most of them, are crossing the placenta. Now the baby is another human being, and the baby's been living inside your uterus for 9 months, having the time of its life, flipping around and floating around and listening to mom's voice, listening to dad's voice, listening to the music you're listening to, getting used to whatever's going on. But it's been living in a really nice cocoon. Now you're starting to labor. Now its cocoon is beginning to squish it a little bit. It's being squished a little bit and squished a little bit more. And suddenly, if it's a head down baby, its head is starting to get forced down into between some bones, and it's uncomfortable for the baby, and the baby has no idea what's going on. But every 3 minutes, it's getting a waft of mom's oxytocin. It's getting a waft of mom's endorphins. It's getting a waft of mom's adrenaline. It's getting a waft of mom's cortisol, among its own things. And in some way, for 9 months, that baby has been communicating like in a symphony with its mother back and forth, telling mom what it needs. Mom telling baby, I'm good. You're here. I've got you. I'm taking care of you. You're fine. Baby feels safe. Everybody feels great. Suddenly that world is changing. And so baby's communicating with mom through these hormones. Right? Then the bag of waters breaks. And now it's really getting intense. And now baby's starting to work its way, rotating and doing its reflexes to get it to change and rotate its head to come down to the pelvis. And its head is getting squeezed every 3 minutes with a contraction. And it's in a lot of discomfort, but it's still communicating with mom. Mm-hmm. Right? This is why labor is painful, because mom and baby are communicating, and mom can help baby navigate the process of birth, which is something that's brand new to this baby. Mm-hmm. What happens when you give the woman an epidural?
No pain, no connection.
You disconnect the baby from the mother.
Yeah, baby is like on his own.
Right. Suddenly mom is not secreting endorphins, adrenaline, cortisol, and or oxygen. And again, these are just the 4 that I come up with. There's all things that we don't really understand. There's many other things they don't understand. But you suddenly give her an epidural, mom is laying on her side, And baby no longer is getting those signals from mom, whatever signals those are. They could be electromagnetic, they could be other things. And suddenly they're gone. And now the baby's left on its own to deal with contractions. But now, because of the way the system works, because you got an epidural, guess what happens to your contractions? They space out a little bit.
Mm-hmm.
So what do?
C-section.
Well, no, first that's coming. That's coming. First they add Pitocin.
What is that?
That's to make your contractions come back. It's a drug. It's a drug to induce labor.
So you prevent it, then you...
Right, you
wanna
made her
bring them
comfortable,
back.
but now her contractions are spaced out. And because we're on a time limit in the hospital, because we need the room, we can't just let her sit here for 2 days. We have to get her moving. Many women who are listening to this podcast will have known the doctor says you're not moving fast enough. Fast enough for who?
Yeah.
Who decides whether you're moving fast enough or not? Some guy named Friedman came up with a curve. It's a ridiculous curve. Friedman's curve was God, I'm really getting off track. It all ties together. Friedman was a guy in the 50s and 60s who came up with an idea that all women having their first baby or second baby should labor and dilate at the same rate once they reach active labor, which in those days was beyond 4 centimeters. But again, and I'm not a scientist, and you'd think that scientists would think this out.
Nope.
And I hope somebody can correct me if I'm wrong, but the way a curve is designed is from a scattergram of different numbers. They're scattered all over the place, and then the curve is the median that runs right through it. Okay, so now they use the curve to say if you fall below the curve, you're not moving fast enough. But the original curve, 50% of women were below the curve. So they've just decided now that 50% of women are not moving fast enough.
No, you have to adjust the curve.
This is idiotic. And these are the people that are running our system. This is just another example of the inmates running the asylum. They're not thinking. So you're not moving fast enough, so we have to add Pitocin in my country, Syntocin in Europe and Australia. Same thing. It's synthetic oxytocin. And so the contractions get strong again. But baby doesn't have mom to help compensate it. So now the baby's getting squeezed a lot more. And so now they're monitoring the baby because now you've got an epidural, you've got drugs going in, and they're monitoring the baby, and they suddenly don't really like the way the baby's heart rate's looking. Well, duh. All right. Mom's blood pressure may have bottomed out a little bit because you gave her an epidural, which is not uncommon. That's going to affect the baby's heart rate. Baby's now getting possibly hyperstimulated because you're overstimulating uterus because mom is comfortable. So your job is just to get that baby out as fast as possible. So let's just crank up the Pitocin. The baby's heart rate suddenly begins to look not reassuring anymore, and you're only 7 centimeters dilated because you've had more unnecessary vaginal exams. And they say to you, you're not going to deliver real soon. I think the baby's in trouble. Baby's not tolerating labor. The number one diagnosis now for cesarean section in labor is fetal intolerance to labor, which should be called fetal intolerance to artificially induced labor, but that's not what it's called. And then they take them for a C-section. And therefore you end up with your 600,000 women who are having unnecessary C-sections. I've simplified it to some degree, but that's sort of what's happening. This is not a hard thing to fix. If we would just let women labor on their own timetable and leave them alone, even if they felt safer in a hospital, just let them come to the hospital, which of course is a disruption in the process, but let them come in, answer your few questions, and then leave them alone.
In their room?
In the room, let them walk around, let them eat, let them get in the shower, let them do the same things they might do at home. But if everyone feels safer because they're in the hospital, fine. But the hospital can't do that. The risk managers of the hospital and the people that run the hospital have no concept of what normal mammalian birth is like. They've lost the ability to. They've never seen it. There's a documentary that came out, probably the Bible of documentaries for birth, called The Business of Being Born, by my colleagues Ricky Lake and Abby Epstein. It came out, I don't know, I think 10, 15 years ago. And in there, they are talking, there's an interview where they're talking to 3 residents in labor and delivery, 3 female residents, and they ask them, how many of you have seen a natural childbirth? And none of them had seen one. They've never seen a woman give birth without meddling, because none of them have ever been to a home birth. And in the hospital, almost every woman is labeled high risk and therefore needs something done to them. So, And then they don't even watch labor in the hospital because doctors in the hospital are off busy doing other things. They're only called to the labor room by the labor nurse when something needs to be done, like the woman needs to have her membranes ruptured or a vaginal exam or order Pitocin or catch the baby. That's what they go. But they never sat in a room for 2 hours in a corner doing absolutely nothing, just watching her freely move about and move. They're not taught that. I mean, I can say this openly because I spent 28 years working in a hospital system and left the hospital system, sort of forced out. We can talk about that if you want. And then the next 12 and a half years I spent birthing with midwives at home. And the difference was stunning. What I saw in the home setting was so much more beautiful, and the outcomes were so much better, not even just for what was considered low-risk moms. I took care of what is traditionally called high-risk moms, breeches, diabetics, twins, at home, because there was no law against it in California for me as a physician. California had laws that prevented midwives from doing the things that they were trained to do. The legislative process, again, was influenced by the industrial lobby, the American College of OBGYN, and the American Medical Association and stuff. They are lobbying legislators who don't know anything about birth to keep them in control so that ACOG can stay in control. So they tell them things that benefit ACOG. They don't tell them things that necessarily benefit the women of the state of California.
Let's get back to C-section. Let's say a woman has a successful C-section. What's the worst, or what are the biggest dangers to a woman and to a child in case of a successful C-section? No one's being hurt, and etc.
Okay, so she has a C-section, and for whatever reason, it doesn't matter whatever reason. She heals fine. The baby did fine.
Yes.
So the baby doesn't have any of those things we talked about earlier, like developing of autoimmune disorders or anything like that. Baby's developing fine. And again, most babies from cesarean sections, because of the strength of our design, will do just fine. And the mother had an incision, had it sewn up, had her skin closed. She didn't get a wound infection. She didn't get a problem at all. So she's fine.
How common are those infections?
What's that?
How common are those infections?
Well, skin infections are not uncommon, especially in women who've had a long labor and then have a C-section. They're not serious. The wound can open up a little bit. It just requires some time, and it will close by what's called secondary intention. And it's annoying, and it's a problem, but it's not major. So you're saying a woman that gets through a C-section and she's perfectly fine?
Yeah.
Okay.
That day, she's perfectly fine that day.
Okay, so she has to recover from that. So that's a major surgery, major abdominal surgery. You've cut through the muscles, they cut through the uterus. So it's going to take 6 to 8 weeks to really recover most of those muscle functions, most of those things. So during that time, things are a little bit slower. If she has 2 or 3 other kids at home and now a newborn baby, that's going to be a little bit harder for her. Okay, she could have more blood loss. I mean, you can have more blood loss from a vaginal delivery too, but she could have more blood loss, so she's going to be anemic. That's going to be slightly make her recovery a little bit slower. Again, she will recover. They will do fine. I mean, cesarean surgery is major abdominal surgery, but obviously doctors are very good at it, probably because they do it all the time. Mm-hmm. You get very good at it, but it's not without its potential complications, and those are mostly will be seen downstream. So when you do a major abdominal surgery on someone, and they've healed perfectly, and now 6 weeks has gone by, and they're back at full activity, they're driving their car, they're picking up their kids, they're doing all the things that they're normally doing. Their periods come back eventually. The breastfeeding went without a hitch. We're just talking about that normal. So what is the downside of a cesarean section? Well, one of the first things that I have learned is that doctors do not believe cesarean sections have downside risks. Mm-hmm. Why do I say that? I'll say that because as a breech practitioner for most of my career, especially when I left the hospital and was doing them at home, and people would come to me for an interview, they'd be 38, 39 weeks pregnant. They're in a tiz because now they're breech and the only option they're being offered is a cesarean section. They come to me and they'd tell their history, and I would talk to them, and I'd look at them, my baby on ultrasound, and I'd say, you meet all the criteria for a safe attempted vaginal delivery for breech birth. But one of the questions I would ask them is that, is the doctor who told you you had to have a C-section for this baby, your first baby, did they ever ask you if you want more children? And the answer is universally no. The doctor's never asked because the doctor isn't concerned about what happens to this woman down the road.
Mm-hmm.
His concern is that he thinks that a C-section is safer for this baby, and therefore it's the right thing to offer without ever looking downstream. Again, a bit of stage one thinking. If I do a C-section for this baby, don't ask the follow-up question, and then what happens?
Mm-hmm.
But now you've got a woman who's got what's called a scarred uterus. And she may live in a community that is very VBAC unfriendly, vaginal birth after cesarean unfriendly. And they may say to her initially, well, if you have this C-section, you can VBAC with your next baby. But then you're pregnant with your next baby and you find that the language and the subtle coercion is such that they're telling you that it's dangerous and we don't support it. And so now you've got that stress to deal with, right? You also have the risk of complications that can occur from a surgery that don't show up right away, like scar tissue, adhesions, bowel obstruction. Those things can happen months or years later after you've had any major abdominal surgery. So they're always in the background,
Mm-hmm.
right? Now, you're pregnant with a second baby.
Yes.
If you get pregnant too soon, like in less than 6 months from the time you deliver your other baby, they're going to tell you that the risk of rupturing your uterus is so high that you should have a repeat C-section. That also is false. It's higher, but a higher chance does not mean high risk. And ultimately, the decision about how to proceed should belong to the adequately informed woman. And in order to adequately inform a woman, you need to tell them actual risks, not relative risk. Relative risk is completely different than actual risk. So let me explain that for a second. We'll get back to the... If something happened in California one time last year, the actual risk is 1 in 40 million. Everybody agree we have 40 million people, which is crazy, by the way, that California has 40 million people. I was talking to somebody in Canada yesterday, and I said, yeah, we have more people than Canada in our state. Canada has like 33 million people.
Yeah.
So 1 in 40 million. Now, say this year it happens 10 times. Disease X happens 10 times instead of one time. Somebody who's trying to promote funding for disease X is going to go to Sacramento and is going to say, there's been a 10-fold increase in
Correct.
disease X.
From 1 to 10.
Right. But the actual risk is still 1 in 4 million.
Correct.
Okay, so is 1 in 4 million any significantly different to you, Apollo, than 1 in 40 million? No, they're both zero.
Correct.
Yeah. I mean, if you round it to the nearest number, it's zero. It's still zero.
It's still zero.
Right? Yet, if you want to use your bias to promote doing something, you'll use that. So that's the difference between relative risk and actual risk. And I would suggest to your listeners that a lot of their obstetricians know relative risk, but they have no idea what the actual risk is.
Mm-hmm.
So you're going to be taught if you've had a C-section that you have to wait at least, they'll say 18 months before you get pregnant again. And if you get pregnant before that, they're going to tell you need a C-section. They read an article once that said that. They've never looked any further into the research. They don't understand about giving information so the woman has the right to make informed consent. They think that they are doing good, but they've lost something in their ethics has been off tilt, because ultimately that is not their responsibility. Their responsibility in informed consent is there are three phases of informed consent. One is to give objective information. So the doctor gives his information what he thinks. Excuse me, objective is not what he thinks. Objective is what the information shows.
Based on something.
Right. Then then it's the doctor, because he's an expert, has the right to give his subjective opinion. You know, the data on breech birth shows that breech birth can be successful in the right hands, but I've had bad experiences with that, or I don't think it's a good idea. Okay, that's legitimate. Mm-hmm. But the third phase is called support. And if the woman says, I hear what you're saying, but I think I want to go for a vaginal breech birth, or I want to go for a VBAC,
Doctor should support
the doctor should support that. Now, support can look many ways. It could say that, sure, I'm in with you. Or an honest doctor would say, I support your right for a VBAC, but my hospital doesn't allow it. So you need to look elsewhere you need to look to another hospital. Or I support your right for a breech delivery. I think the literature does support properly selected breech in skilled hands. I don't have skilled hands, So why don't you call up Dr. So-and-so at...
They will never do that.
But they don't do that. Correct.
They will lose money.
Ego and money.
Ego. Come on. Ego? We're
don't
talking
think-
about people's lives.
you-
Ego?
Well, doctors are known for having very large egos.
Playing God?
Yeah. I mean, there is still that. And by the way, when you have life in your hands, sometimes it does start to become something you have to keep reining in, that you're not that person. But ultimately, medical ethics dictates that the decisionally capable woman has the right to make any decision she wants. She has the right to informed consent. She has the right to informed refusal. She has the right to uninformed refusal. She could say something like, I want to do this. And the doctor says, well, let me tell you why that's not a good idea. I don't want to know. I'm just doing this. And we ethically are supposed to support them. We're not supposed to call Child Protective Services. We're not supposed to coerce them. We're not supposed to threaten them.
Because people are not slaves anymore.
Not
Right?
in America. I mean, there are other countries where you don't have the same Bill of Rights and things that we have here. But in America, you have the right to say no. And yet women have been bullied to think that they don't. And that bullying is going on over and over and over again. So you have that risk when you have that C-section of having that argument coming down the road. You also, once you've had one C-section, your risk of something called abnormal placentation, better known as something like placenta accreta or placenta previa, where the placenta presents covering the cervix or the placenta grows into the uterine wall,
No.
far more likely to occur after you've had a C-section. It's not very likely, even then, but it's more likely than a woman who's never had a scarred uterus is very unlikely to have those things. Once you have one C-section, it's higher. If you have a second C-section, it's higher than that. If you have a third C-section, it starts to get relatively significant.
2 digits percentage-wise?
By after your third C-section is close to 2 digits, yeah. It's close to 10% probably. And nobody tells them that. And nobody tells a woman who has that first C-section for breech. Nobody asks her that. They said, I mean, she may want 7 children.
Mm-hmm.
And now you've put every one of the next 6 children at greater risk than you would have by letting that woman have a vaginal labor with a breech baby with somebody who knew what they were doing. And this is considered the good practice of medicine. And what I did was supporting breech delivery in the home setting or even in the... My privileges were not renewed because I refused to comply with the request that I stop doing breech delivery in the hospital.
You got a request from management?
From the OB department and the medical executive committee, because we were making the anesthesiologists and the pediatricians and the labor and delivery nurses nervous, because all they had known for all the years before I came there was that breech is dangerous, have a C-section, and all the OBs, that's all they did. And when I came in, I brought in different set of skills, sort of a different set of chutzpah, if you understand, that's a Yiddish word for maybe boldness, that I was well trained to take care of these things. I was lucky. I was still trained in an era where breech was considered just a variation of normal. Mm-hmm. We can digress for a second. I went to medical school at the University of Minnesota, and one of those sliding door moments in your life, and people have them, sometimes you don't know them, but this is one where you actually can witness it, is on the 3rd Wednesday of March in the 4th year of medical school, you get an envelope that tells you you've been interviewing for residency programs at different places, and they rate you and you rate them, and it all goes into a computer, and it's called the match. And on that Wednesday, you get an envelope that tells you where you're going to be spending your next 4 years. And I matched in Southern California. So if I had matched in Iowa or Colorado, which were some of my other choices, I can't imagine how different my life would have been than end up going to California and spending up 40 years in California. But I matched in California at Cedars-Sinai Medical Center in Los Angeles, which is a very prestigious hospital. They do good work there. They do stupid things there too, but they do good work there. And as part of the residency program, we were affiliated with, at that time, with LA County, which is Los Angeles County, USC, which is University of Southern California Women's Hospital, LA County USC Women's Hospital, which in 1982, 83, 84, 85 was the busiest hospital in the United States. They were doing about 22,000 births a year there.
In the whole country, the busiest.
The busiest hospital in the United States. 22,000 births a year, which is, Apollo, 65 babies a day.
Yeah, a day.
65 babies a day. I was there for 4 months, every other day. So that's 60 days, 65 babies a day. You can do the math. Now, if breech babies are 3 to 4% of all babies born, then you can, with 65 babies a day, I'm seeing 2 to 3 breeches every day.
Mm-hmm.
And I'm seeing 1 or 2 sets of twins every day. And so it became something that was routine. And more than it was routine, it was something that we as OB residents loved to do because it made us feel like we were doing something. Catching a vaginal delivery was fun, but it was like boring after a while. But doing a breech baby, doing twins was exciting. And in those days, we didn't do passive. We didn't do all fours, passive waiting, watching. Everything was active. Once we could get our hands on a baby, we'd pull the baby out. We'd do those. So we got very good at things like breech extraction, putting on forceps, vacuums, things like that. You can't do that stuff anymore, and that's probably for the better overall for humanity. But this was more like just volume. We were inundated. Most of the women were illegal, and most of them didn't speak any English. And we just took care of them, and it was an assembly line, and we moved them in and we moved them out because we only had 24 beds, and we were doing 65 babies a day. So you can figure out, the craziness that was County Hospital in those days. But I got very well trained.
What was your successful rate?
Oh, I have no idea. As a resident, you don't keep track.
No, as a doctor, in your 28 years career, what was your success rate?
Another thing, doctors don't keep track either. I didn't keep track of my numbers. It was not something I did. I only began to keep track of my numbers when I went in and started doing home birthing, and I started following what the midwives were doing, and I kept a logbook. And in those days, the logbook was handwritten. I kept a handwritten logbook of over the 400 and some deliveries that I did in the home setting over 12 years. I have every one of them charted. Of all the deliveries I did over the 28 years in the hospital, I have no idea.
Out of your 400 deliveries at home, how many of the women went to the hospital eventually?
My transport rate was about 7%.
Transport rate is when women go to the hospital because
from
something
home.
goes wrong.
So about 93% of women who started at home ended up delivering at home. Mm-hmm. And about 7% went. And again, it was much higher. It was probably about 10 to 12% of first-time moms and about 1% of second-time moms.
Only 1%?
Yeah. Oh, second-time moms are, if you ask any birth practitioner, if you get a new client and she happens to have already had a vaginal delivery, we're thrilled because
they know
we call those are very likely to have what's called a butter birth, which is like, it's just, baby's just going to slip and slide right out. And it's going to be easy and we're not going to be there that long. So that first time labors are longer. But that's where I got my training in breech delivery. And I did breech for most of my career. I think there was a period of time after the year 2000 when hospitals became very anti-breech delivery. And for reasons that are still, to me, illogical to this time, that they cherry-picked certain few articles that suggested cesarean section was safer for breech than vaginal delivery. And they chose to do that. I believe they chose to do that not because it was safer, but because it was economically and expediently more beneficial to the hospital setting. So in other words, the science proved what the hospital wanted, because there was plenty of science that proved that vaginal breech delivery is certainly reasonable and better for mom and baby, and they ignored that data. So in the year 2000, breech delivery essentially stopped being taught in residency programs anymore. And so for the last 25 years, young doctors coming out of training are not skilled in that, and they are now the bulk of the people out there practicing, which is why it's so hard for a woman who has a breech baby to find any choices anymore.
Breech baby is percentage-wise how common?
3 to 4% at term.
3 to 4, okay. What's the worst that can happen during the breech?
Same thing, worst thing that can happen to a head-down baby. You could have an intrapartum fetal demise. You could get a baby. The scare is that the baby's head could get stuck or the umbilical cord could prolapse, and you're not going to be able to get the baby out in time. But again, if I want to if I want to scare little kids at a campfire, it's pretty easy to tell a scary story. That's what this is. Because this is not what normally happens. And certainly when you have the proper skills, these things are very rare. Again, I'm a testament. And I'm just one of many, many people who are my colleagues, many of which who are my mentors. I walk on their coattails because they taught me things. After I finished my training, I learned from so many people. I don't want to start naming people because that'll leave somebody out, but they know who they are. And I still work with some of them to this day. And trying to advocate for these sorts of things. We go around the world and we teach these skills. I try to keep them alive because midwives are very interested in knowing how to help their clients do with breech and twins, whereas obstetricians are very obtuse and are not interested. And that's what's amazing to me is that they don't want to learn the skill and then they want to lobby legislators to prevent midwives from being able to practice the skill so that all these women are forced to have C-sections. And if I can tell you that over 90% of my breech babies delivered vaginally, and if a doctor sections 100% of breeches, then you could logically make the argument that 90% of his C-sections were unnecessary.
Unnecessary.
Right. But he will never say they're unnecessary. And he will never accept the consequences of what happens downstream. If you want, I don't know if you can edit this if you want, but I can give you a sort of a horrible example.
No, please.
Okay. So there was a story of a mother and a baby in Arizona a couple years ago who had a uterine rupture in labor at home and ended up, she passed away and the baby passed away.
Oh.
Now, her story is she's had a C-section for first baby. Second baby, she'd had a successful VBAC at home. And this was her second VBAC or her third baby at home.
VBAC is
vaginal birth after cesarean.
C-section.
Yeah. And so there are some issues of whether or not the midwife was on top of things and the midwife might have been negligent and whatever. Doesn't really matter at this point. But all the investigatory bodies, the medical board in Arizona, the police in Arizona, the press in Arizona, they were all over this midwife for not managing this properly. I don't know if that's true or not. I've never had a chance. I don't want to ever pass judgment on that. But I know one thing for certain. I never saw anywhere in the press or in the records or in the medical board issues anyone asked the obvious question that was to me the first question that I looked at when I looked at this story. And that was, why did she have her first C-section?
Yeah, but that's history. She already had it. That's it.
No, but why did she have it? She had it because she had a breech baby. And she was not offered a vaginal delivery. So had she been offered a vaginal delivery with her first baby and had a vaginal delivery, she never would have had a ruptured uterus in her third pregnancy and passed away and lost her baby.
Yeah, but maybe she regretted after doing the C-section. Then she had her second child vaginally, and then the third child.
Right, but I think what you're missing my point is that do you think the doctor that did her C-section for breech even knows that she's dead? Do you think that the doctor takes any culpability in the fact that she had a ruptured uterus and dies? Because he did not offer her a very reasonable choice. He skewed his counseling, or she, could have been she. They skewed their counseling to funnel her into something that she probably didn't need that ultimately led to a problem. The reason I point this out is not to be specific in this case. It's just to say that when you mess with Mother Nature, there are downstream consequences. And in this case, the ultimate downstream consequence occurred. Right? Does uterine rupture occur in a woman who's never had a C-section? Yeah. But it's like 1 in 8,000, 1 in 10,000 pregnancies. It's not something that you'd even blink an eye at.
0.1%.
Oh, 0.00, yeah, something like that. It's extremely small.
In 10,000, it's 0.001,
0.001, I think. 0.001. No, 0.1,
0.01, correct.
0.01. Right, okay, 0.01. So 99.99% chance it's not going to happen. Right. That's normal. So when you asked about what are the downstream consequences of a woman who has a perfect C-section. And this is potentially one of them, is that there are downstream consequences to her. And then there's a potentially of scar tissue, as I mentioned, which can cause fertility issues. there's all the extra testing that might go on because now she's a VBAC, and the extra fear that might be laid upon her in future pregnancies, depending on which practice she's with and who she's with. So it's not without, C-sections are not innocuous. That's my point.
Do you agree that lobotomy in the 50s to 60s were unnecessary and stupid?
You're asking me about lobotomies?
Yeah. Just yes or no?
Yeah, I mean, yes, they were probably brutal and unnecessary.
Would you say?
But I don't. Again, honestly, it's outside. I saw Shutter Island, so that's the only thing I know about lobotomy.
But would you say C-section right now is just like the lobotomy in the 50s to 60s?
No.
Science backed it up back then?
No, it's because the C-section has very, very necessary indications. I'm not sure lobotomy ever had a necessary, but again, I don't know enough about that, but it's an interesting analogy that you bring up. C-section I would not put in something that is a barbaric, unnecessary procedure. It is absolutely necessary and life-saving.
But back then they believed in it, in lobotomy. They were doing it, science-based.
Well, that just goes to show you what
science can be wrong, right?
Science is often wrong.
Yeah.
All right. And science, by the way, doesn't mean what people think it means anymore. Science used to be, let's do a study and see what the results are. Now science is, here's the results we want. Let's find a study to prove our results are correct.
Or here is the money.
And you know that because we saw all the exposure during the times of COVID and things like that, where even the supposedly reputable New England Journal of Medicine and the Lancet published false data that had to be retracted, and they pushed these things through peer review when they should never have gotten through peer review because they wanted the narrative out there that hydroxychloroquine and ivermectin were horse medicine and unsafe. And so they pushed that, and that the vaccine was safe in pregnancy, which was with a New England Journal article, which they played with the numbers, fraud and committed fraud. They committed academic fraud. And the more I've looked at the history of medicine, the more I've looked at it, it's been financially motivated and not necessarily evidence-based. And again, the term evidence-based doesn't mean what people think it means anymore either, because they say, well, I want to follow evidence-based medicine. Well, evidence-based medicine is only as good as the evidence that you're using to make your evidence-based medicine. And if the evidence you're using is a skewed science and these skewed research papers, then evidence-based medicine is like garbage in, garbage out, which we used to say about computers, right? Right.
In regards to COVID, do you know the name of the first male that was vaccinated with the COVID vaccine?
No, tell me. I don't know.
Just to bring the evidence and to get the proofs right, I'm going to use the ChatGPT. I'm going to ask it live on the show. Tell me, what was the name of the first male, not female, but the first male that got vaccinated from COVID-19 in the world? The first male, what was his name?
Just thinking.
According to the BBC, William Shakespeare, an 81-year-old man from the UK, was the first male to receive the COVID-19 vaccine outside of clinical trial.
So why do you bring that up?
What are the chances? What are the odds?
What are the odds?
William Shakespeare. That's his real name.
Yeah.
What is it? A theater? What's a very common phrase of William Shakespeare? All
life is a show. Is a stage. All life is a stage, right?
Men or women are merely players. How can you imagine?
No, look at that. Wait, I got goosebumps right now.
Can you imagine, like, you're having this vaccine approved? No. Please, you're the first male? Yeah. What's your name? William Shakespeare. Oh, man. Is there any other? Like Thomas something, Thomas Stevens. Yeah, you go first because the media is going to eat us alive. Nope, they did it.
Oh, my God.
The first male, William Shakespeare.
How did you even...
I got a guy like 2 weeks ago and he said, did you know that? I was like, no.
So you checked it out?
Yeah, I checked it out.
Yeah.
I always fact checked it.
Oh, man. Yeah.
William Shakespeare.
Well,
and he died, I want to say, in 6 months.
Yeah. Going back to to obstetrics and stuff. I mean, a lot of times people who are pro the way the system is now will say, "Well, look at us 100 years ago. I mean, women died in childbirth." And I said, "Yeah, you can't compare us to 100 years ago. 100 years ago, we didn't have germ theory. We didn't understand about bacteria. We didn't have antibiotics. We didn't have any of that stuff. So let's go back 50 years, And then their argument completely falls apart because, as I said, 50 years ago,
Even 50 years is too much.
but 50 years ago, we had better outcomes than we have now.
50 years in
And we-
1975, not the 50s, like most of the people would say. Like 50 years ago, yeah, well, 1950. No, it's
No,
like
it's 1975.
1975.
Right. Right. It was continuous fetal monitoring was just coming into play. Friedman's curve, that labor curve I talked about, was just coming into play in the early 70s. And since those two things came into play, the C-section rate, as I said, went from 5% to 33%. We've added in ultrasound. By the way, in 1970, maybe 1 out of every 3 women had an ultrasound. Now, currently, 75% of women have at least 3 ultrasounds.
Yeah, we had our 3.
They're turning on things called this color flow Doppler, which they're using now almost universally. It had a very narrow indication, but then it ended up with something called mission creep, where maternal fetal medicine doctors began turning it on every single pregnant woman. Why do they do that? Because there's an RVS billing code that they can bill, and it adds $100 to $135 more to the ultrasound charges that they can submit to the insurance company without any proven benefit as a screening tool. And I keep saying this over and over again, Apollo. Every time they add something in there, whether it's more ultrasounds, more testing, more inductions, more C-sections, have outcomes improved? And the answer is an obvious no. Well, like I said, in the last 15 years, newborn intensive care unit admissions, this is CDC data, have gone from a little over 5% to just under 10%. So almost doubled in the last 15 years. Now, either we're doing something really bad to make 10% of kids go to the NICU, or hospitals make a lot of money from babies going to the NICU, so they're finding reasons to send babies to the NICU that don't need to go to the NICU just to fill the beds in the NICU. Neither one of those speaks well for the system that exists.
Correct.
Yeah. So we have a system that has pretty much made everything worse. Mothers, babies, outcomes are worse. Yet these are the people that are advising Congress. They're making the rules. They're putting out guidelines. You know, the American College of OBGYN sets the guidelines for most of the obstetrical practices in the United States, most of the hospitals. They fully admit that 2/3 of their guidelines are not scientific.
They admitted.
Yeah, they put out much to their credit, they put out a paper, I think it was 2010, that said that 67% of their guidelines are what are called level C guidelines, which is essentially consensus opinion. Level A evidence is sort of randomized controlled trials. Level B evidence is sort of meta-analysis, chart review, looking back at things. And level C evidence is consensus opinion, that sort of thing. Now, what kind of opinion do you think you're going to get from a bunch of maternal fetal medicine doctors all trained in the same way, sitting around thinking that every time we make an opinion, we're going to increase our own revenue and business because every opinion we make drives more people to come see us as a society. The Society of Maternal Fetal Medicine is as corrupt as the American College of OBGYN, just shy of the corruptness of the American Academy of Pediatrics, which is probably the worst of them all. But the Society of Maternal Fetal Medicine recently, and I think in 2020, changed the definition of growth restriction from a fetus at the 3rd percentile to a fetus at the 10th percentile. Now think about this for a second. What they're saying is that if they define growth restriction as the 10th percentile, they're saying that 10% of all babies in the United States are growth restricted. That's what a percentile means. Correct me if I'm wrong. You're good at this. But, you know, if 10% means if you're below the 10th percentile, that means 10% of people are below the 10th percentile, right? So they're saying 10% of babies are growth restricted. Think of how much business that increased them from 3rd percentile to 10th percentile.
3x.
It's incredible.
Incredible.
And they're going to be scanning these people. Every time they label a baby growth restricted, what does that do to the mother's psyche? I got to get my baby out. My baby's not growing well. I'm nervous. I'm living my life with pregnancy while I'm worrying all the time. I'm worrying. You're making me worry. Planting seeds of doubt is what the medical mice birth model does better than anything else. It's your very first prenatal visit. You're a very healthy woman. You come in, you're 10 weeks pregnant. They hear a heartbeat. They say, great, this is fantastic. But you know, you're over 35. So we want to do some genetic testing. And we really think that we probably will talk about maybe inducing your labor at 39 weeks because your placenta, because you're old, your placenta may give out. And they're telling them this stuff at 10 weeks. So what's the woman thinking about for the next 30 weeks? There's something going to go wrong with my pregnancy. Why do they do that? Well, they do that. I believe that doctors do it as a psychological thing, that doctors do that because they're anxious, because doctors are scared about pregnancy. They've been taught to be scared about pregnancy, so they project their anxiety in the guise of giving information so that the woman can make informed consent. But they skew their counseling. There's no reason to tell a woman, because you're 35, that's a problem. So this brings me to the whole category of your listeners. They've all heard the term high-risk pregnancy. I could ask 10 OBs, 100 OBs, for the definition of high-risk pregnancy. None of them would have a good answer. They would label off things like, oh, over 35 or diabetes or twins or anything like that. But what is high-risk pregnancy? Because high-risk pregnancy is not a number. High-risk pregnancy is something that makes the doctor or the obstetrical system uncomfortable, period. Right? Higher chance of something going wrong does not make it high risk. So let me give you some examples to make that clearer. Doctors will label, like I just said, a woman who's over 35. They'll label her high risk. They'll label a woman who is a higher BMI as high risk. They'll label a woman who's had a previous C-section as high risk.
BMI, body mass index?
Body mass index, right. Somebody who's fat,
yeah,
overweight. All right. They'll label a woman who has a previous C-section as high risk. They'll label a woman who's got diabetes at high risk. Doesn't matter if she's perfectly well controlled. They'll label her as high risk. They'll label a woman who's got hypothyroidism as high risk. They'll label a woman who's potentially got a narrow hips as high risk. Or she's short and her husband's tall. They'll label that as high risk. Yeah, this is what they do. And then the intake forms that doctors use have what's called a problem list. Okay. And the first problem on the problem list in any pregnant woman is what? That she's pregnant. Okay? And where do they get that from? Well, the American College of OBGYN says in one of their guidelines on influenza and pregnancy, this is verbatim, they say pregnancy itself is a high-risk condition. So if that's the prism by which they see pregnancy, and that's the prism by which they teach other doctors to see pregnancy, you can see how doctors begin to see every pregnancy, like I said at the beginning, they see it as a problem, as opposed to the midwifery model who sees it as something that is a normal function of a woman's body that occasionally goes awry, and they're accepting of uncertainty. Whereas doctors don't accept any uncertainty of nature's design, so they'll interject their own things which cause all kinds of chaos, but they don't care about that. So pregnancy itself is a high-risk condition. And you know what? I got caught with that by a woman 3, 4, 5 years ago when I was still practicing. I was doing my usual history taking. I like this story because it shows that even somebody who's as sensitive to the issues as I am can't always get all the OB out of my body. When you take a history, you ask somebody about why they're there. It's called the chief complaint. And then you ask them questions about it. I have a headache, so then you ask all kinds of questions about the headache. And then you do what's called the past medical history. You ask about their meds. What meds are you taking? What allergies do you have? What other medical problems do you have? What surgeries have you had? And you ask about family history, and then you do a review of systems. You ask them about their whole. That's classically the way anyone, whether it's midwifery school, nursing school, medical school, we're taught to take a history. Everybody would be nodding if they heard that part. So when a woman came to me pregnant, and I took her history, and all she is just came to interview me, and this was after over 30-some years of practicing. I ask her about her pregnancy, and then I get to the past medical history, and I say, so do you have any other medical problems? Which is what rolls out of my mouth constantly. And she looked at me, and for the first time in my life, she said, what's the first one? And then I thought for a second, and I just asked her, do you have any other medical problems?
And she had many.
No. What I was asking her was, I'm assuming that pregnancy is a problem.
Oh,
do you catch that?
Whoa.
Okay, it was subliminal. I didn't even know that I was doing that, but I was considering pregnancy to be a problem, because otherwise I should say, do you have any medical problems?
Mm-hmm.
You shouldn't ask, do you have any other medical problems? Because she didn't have any medical problems, and I still use the word other. So I've learned from that episode that even I was indoctrinated way back when to see pregnancy as the first thing on the problem list. And when you see pregnancy as a problem, you treat things differently than if you see it as normal.
That's the biggest gift from God, but we see it as a problem.
That's how doctors see it. And then they go on through pregnancy, planting seeds of doubt, maybe to cover their butt, maybe because they truly believe that these are potential problems. But here's some examples of what they consider to be high risk, but their solution to that is probably carries more risk. For instance, they will consider a woman over 35 to be high risk. So one of the things they'll recommend to her is to induce her labor at 39 weeks. So if I were to ask you, just common sense layperson, which carries more risk, being over 35 or inducing your labor at 39 weeks, which would you say?
39 weeks.
Right. But which one's labeled high risk? Being over 35.
Yeah.
Here's another one. We've already kind of talked about this one. You have a breech baby. Their solution to that breech baby is to do a C-section for that breech baby. Which one actually carries more risk? Having a vaginal delivery of a breech baby that's properly selected with a skilled practitioner, or having a C-section for that breech baby, and that woman wanting more children. The second one.
Yeah.
But that won't be labeled high risk. The first one will be the breech baby vaginally will be labeled high risk. The doing a C-section for breech baby and then putting all her future babies at greater risk, including the mother herself, is not considered high risk.
So it's subverted. So the first time we visited OBGYN was when my wife was, I would say, 6 to 8 weeks. No, doesn't matter. So she went to a visit to this new doctor that she has never seen before. And right away she comes out and she says, I got a prescription. I was like, what prescription? Progesterone. I was like, did they do blood work, any tests? No. So I'm asking the doctor, why did you prescribe a progesterone? Oh, that's because maybe she lacks this hormone. Like, how did you know? Did you run blood tests? No. I said, we're not taking it. Why? Because you didn't do any tests. Well, yeah, you can. If you want, you can skip it. So we changed the doctor. They do prescriptions without any blood work?
I admire you greatly for that, because most people would just trust the doctor. But there's absolutely no reason.
No reason.
And there's no evidence, there's no studies that prove that it's safe to be given in the first trimester. There are reasons to give it in the first trimester that may very well be valuable. People that have repetitive miscarriages, people that have a luteal phase defect, people that have low progesterone. Mm-hmm. But to give it routinely, my colleagues are doing the same thing now with aspirin. Baby aspirin now has become like the miracle drug. Oh, you're pregnant, you should take baby aspirin. No, if you actually look at the literature on baby aspirin, there's a very narrow window of proven efficacy for it, and that is a woman with a previous history of preeclampsia. It may lower the risk of subsequent preeclampsia by 22% or something like that. But now they're giving it to all women, thinking that it's innocuous. Now, it may be innocuous, but has anyone ever looked to see if it's innocuous? Mm-hmm. Again, I don't want to get back and compare it to Ozempic or Thalidomide or anything else, but when are you going to learn your lesson? When do you look at history and say, maybe we ought to test these things out first? These same doctors who tell you not to eat sushi while you're pregnant mm-hmm. will tell you that at 28 weeks, you should get 3 vaccines with 5 antigens in them, and another one at 34 weeks. Now, these vaccines at 28 weeks, the flu, the COVID, and the DTaP. DTaP is diphtheria, tetanus, and pertussis. There are 5 antigens in 3 vaccines. The DTaP vaccine has 250 micrograms of, I think it's 250, might be 400, of aluminum in it. You're giving that to a woman to prevent what? To possibly prevent a baby from catching it later on in life. I mean, in the first 6 months of life before it can get on its own vaccine schedule, which is a whole other topic. But the question you should ask before you give it, before you take a vaccine like that is it safe? And there are no safety studies. There are no safety studies in you and me, let alone pregnant women. Secondly, before you take a vaccine for something, you should ask, what's the morbidity of this disease if I don't take the vaccine? How many babies are going to be affected with pertussis in the first 6 months of life? And the most recent data, I looked into this because I'm a nerd, and I looked into this, and I found that the last data I think was from 2021 that I could find, and there were 30 children that died from pertussis between 0 and 5 years of age. Now, if you believe that there's about 4 million children born every year, that means we're talking about 20 million children.
Yeah. You multiply by 5 years.
Yep.
20 million?
20 million children, and 30 died between age 0 and 5. How many of those died between 0 and 6 months? Not listed. So you're giving a vaccine which carries toxins in it that's never been tested for safety to prevent something that almost never happens.
Why aluminum is in the vaccine?
It makes it work better, supposedly. It makes your immune system react faster. It's called an adjuvant.
Can we consume aluminum daily, let's say with food or something?
There is aluminum in our environment, but I don't know if it's the FDA or whoever makes the safe levels number. I don't know if that's the NIH or whatever. But there is supposedly a safe level. I believe there's no safe level of heavy metals.
Inject it.
Well, of taking it in your body in any way, shape, or form. It's bad enough taking it orally, but orally, at least you have your liver and your other things to help metabolize it.
Mm-hmm.
Injecting it bypasses all your body's defense mechanisms. And so it's even worse.
But aluminum, it's a metal.
Well, they used to have thimerosal, which is mercury.
Mercury.
If you look at the history, Apollo, if you look at the history, in the turn of the 1900s, early 1900s, they put mercury in babies' teething powder.
When I was a kid, I used to have this thermometer, and I've always been told, if I break it, don't get even near to that thermometer because of the mercury.
Well, you're younger than me. When we broke a thermometer, we used to play with the mercury.
Really?
Oh yeah, it was fun to play with.
But it's poison.
It's poison. Who knew? We didn't know. My mom used to put mercurochrome when I got a cut, which is a deep red stuff, it's liquid that you put on a cut. It had mercury in it, for God's sakes. This is what we did. We had arsenic in certain things. We had, the whole idea of polio and the gypsy moth and the story about pesticides being the actual cause of paralysis and not the polio virus. That's a whole other story. There's a book called Moth in the Iron Lung by a guy named Forrest McGreedy, which he's written several good books. He wrote one called Crooked, about smiles, about babies that have cute little smiles where their mouth is a little crooked and everybody says, isn't that cute? So no, that baby has facial paralysis, probably from a vaccine. And then he wrote one called The Autism Vaccine, which was about diphtheria. They're very good. They're very good books to look at. But getting back to my purpose about talking about these things that doctors consider risky and don't consider risky is that, again, sushi's not good. 5 vaccines in pregnancy, that's okay. Don't feed your baby. There's something about don't feed your. I'm drawing a blank on it. Don't feed your baby certain food, but give it hepatitis vaccine when it's new. I'm drawing a blank on what I was comparing. I have all these great comparisons as part of my course.
But Hep B is for junkies, for drug addicts, and for prostitutes.
Yeah, Hep B is the stupidest vaccine to give to a newborn ever thought of. But as you and I were talking before we started, it's a gateway drug. It's to get parents and into the mindset that vaccines are useful.
Okay, so I'm 37 years old.
Yeah.
How can I get Hep B right now? Even to use how is it called when you get the drugs? That word. This plastic thing.
Oh, syringe.
Syringe.
Yeah, IV drug abuse.
Yeah.
Sharing needles is what.
Share a
one way-
needle or
Yeah.
have sex with a prostitute that has a Hep B?
Yeah, pretty much. Pretty much. Theoretically, if somebody had active hepatitis B and maybe you drank out of the same glass or something like that, it's not airborne. You can't get it from hugging. I don't even think you can get it from kissing because saliva is really antiviral.
So where can a newborn baby can get Hep B?
Can't. If the parents are hepatitis B negative. And here's a question I've always asked. First of all, pretty much everybody who's had prenatal care is screened for hepatitis B. And if a parent comes in off the street without any prenatal care, they can easily run a hepatitis B screen on the mother and get it back in a few hours from the hospital. So they don't need to give the baby hepatitis B vaccine. But the logic behind it doesn't make any sense at all. And I have the same question about tetanus. You know, if you step on a rusty nail, you're supposed to get a tetanus shot. But the truth is, your body takes about 2, 3, 4 weeks to develop an immune response from the from the tetanus vaccine.
Say that once again. Once you step on a rusty nail, you have to get the vaccine.
They want you to get a tetanus shot. Okay, that's
and
what we were always taught.
Works only after a few
It
weeks.
takes several weeks for the vaccine to start producing something called IgM, which is the initial. It takes. So by that time, you're already infected with tetanus.
Correct.
So here's the same thing with hepatitis. If you're born to a mother with active hepatitis, what is giving the hepatitis vaccine going to do for a baby whose immune system, first of all, isn't even barely functioning yet? So he can't really develop immune response. What the baby needs is what's called hepatitis big, or H-big, which is hepatitis B immune globulin, which gives the antibodies to the baby to fight the hepatitis and helps the baby wipe out the circulating hepatitis virus. Giving hepatitis vaccine to a newborn baby who's been exposed to hepatitis makes absolutely no sense to this brain right here. And I've never been able to find anyone to explain to me why giving hepatitis vaccine, even if the mother has active hepatitis, is going to be helpful. It seems stupid.
She already has one.
Say again?
She has already Hep B. And the kid as well, right?
If a mother is one of those women that has hepatitis B, the baby should get immune globulin after it's born, should be tested and make sure it doesn't already have hepatitis. Get immune globulin, it's fine. But giving it a hepatitis vaccine that contains 250 micrograms of aluminum in a newborn baby, and by the way, the dosing of medicine for babies is based on fetal weight, is based on weight. Antibiotics, anti-seizure medication, it's all calculated based on fetal weight.
But not the
Vaccines, baby weighs 5 pounds, baby weighs 10 pounds, gets the same vaccine. You can tell it's not scientific. It's almost robotic. It's actually scary that some of the most intelligent people go to medical school and then for some reason lose their ability to have logical reasoning and questioning, challenging things. Raising their hand from the front row and saying, or the back row and saying, that's where I sat in medical school, was the back row. I used to play hangman with my friend Lex. Was raise your hand and say, excuse me, that doesn't, giving hepatitis vaccine to a newborn baby doesn't make any sense to me. Well, if they're exposed to hepatitis, well, first of all, the mom doesn't have hepatitis, so how could it be exposed? Secondly, if it's exposed to hepatitis, you got to give it H-big. But how does the vaccine help the baby? What are you talking about? Why would you give it? And I don't know the answer to that. And I've asked great people like Paul Thomas, and he's agreed with me. He says it doesn't make sense. I don't know if you know who Paul is. Paul's a pediatrician who's written some books. He got a new book out called Facts, which I would recommend people look at too. If they've got kids and they want to decide what to do. He did a study that he lost his license for because it
you can do a study and lose your license?
Yeah, he published a study of his own clients, and basically it said he had a population of 10,000 or so kids, and about 8,000 had been vaccinated, and about 2,000 had not been vaccinated. And he looked at about 18 or 19 different areas of health, things like ADHD, eczema, colitis, Crohn's disease, autism, asthma. And in every single category, the unvaccinated kids were healthier than the vaccinated kids. And for that, the Oregon Medical Board suspended his license. He fought them. He eventually, I think, got his license back, but he wasn't allowed to talk about vaccines with his patients. So he finally surrendered his license, and now he's free to speak. And he's with Children's Health Defense TV, and he's got a podcast called With the Wind podcast.
Paul Thomas,
MD, be a great guest for you. Right?
That's crazy.
Yeah.
You tell the truth and you lose your license.
Yep. Oh, look at all the doctors who lost their license for telling people not to get the COVID vaccine.
Yeah, but that was bamboozling us in 2020. But
Yeah.
And he was not supposed to talk to his patients about the vaccines.
No, he was supposed to skew his consent because that's what the big pharma and big medicine wanted. Look at most pediatricians these days are really between an ethical rock and a hard place. And I think a lot of them have just put their head down. As I said earlier, they have sold their soul to keep their practice instead of keeping their soul and losing their practice, because they are prescribing poison to people for profit and with no evidence of benefit in many, and no scientific evidence of safety because they've never been studied. The hepatitis vaccine that's given to babies, if you look at the package insert, was studied for 5 days.
You're kidding me.
No.
5 days.
5 days. All right. A lot of the vaccines were studied for less than that. And sometimes maybe a couple weeks. They never looked a year down the line, saw if there's a problem. If a baby develops seizures or some other, or regressed in their milestones or whatever, a week out, they were excluded. They were not part of the study. And yet they pushed this through. This is how what power corrupts, and absolute power corrupts absolutely. So Big Pharma is the number one sponsor of medical schools. It's the number one sponsor of TV news networks. It's the number one sponsor of politicians. You figure it out in your head.
So I was born in 1988. I grew up in the 90s. I went to school. Our school was not big, let's say 700 students only, right? So I had 25 to 30 classmates. I had, let's say in my childhood, I had, let's say 100 friends or 100 people that I knew personally. I have never ever heard in my life about myself or other kids, my other friends, acquaintances having peanut allergy, dog allergy, autism, or something else. I used to have asthma. But the allergies, the first time I heard about the peanut allergy, I would say I was like 18 years old. Maybe I saw this in the movie. And this is a common thing here in USA, right? How come?
Because they use peanut allergens apparently in vaccines as an adjuvant. So people created antibodies to that. There's a documentary called The Diabolical Agenda. I don't know if you've seen it. Mm-hmm. It was produced by Andy Wakefield. You know Andy Wakefield? No. Okay, Andy Wakefield is famous for the fact that he came out. He was an endocrinologist in England, and he found that he was seeing a lot of colon problems in babies that had been vaccinated with the MMR vaccine. So he wrote a paper stating what he saw. And for that, challenging, he didn't say the MMR causes autism. He just said there's an association between autism and babies with gastrointestinal problems that he's been noticing. And for that, he was pilloried. And they took away his license in England and all that. And he went on to redeem himself and make lemonade out of the lemons. He became very well known. He produced he directed a very famous documentary. It came out about 5-10 years ago, Vaxxed. I don't know if you've heard of Vaxxed. He just had a movie that came out last year called Protocol 7. It was about Merck falsifying its mumps data. But he did a documentary. It's a very short documentary. It's less than an hour, I think, on it's called The Diabolical Agenda, and it's based on the fact that in Kenya, the World Health Organization, Bill Gates affiliated with them, Tedros, the guy that's still running it now, they gave tetanus vaccines to women in Kenya laced with human chorionic gonadotropin.
What is that?
HCG. That's your pregnancy hormone.
Mm-hmm.
It was put in the vaccine on purpose. What happened then is that women made antibodies to HCG.
Oh.
So when they got pregnant, they attacked their own early pregnancies and they had miscarriages or they had infertility.
And it's documented?
It's documented.
Fact-checked?
And the only person that ever suffered for this was the doctor who disclosed it. He apparently died of COVID. Okay. But nobody who was behind it has ever been perp walked, spent a day in jail, paid a fine, nothing. But this is typical. This is what goes on in the world. Doctors or scientists or politicians or lawyers or anybody who's been behind these things, or so-called humanitarians like Bill Gates who've been behind these things, have never paid a price.
And never will.
Yeah,
Afterlife only.
I agree that it seems very unlikely that they will ever pay a price. I would love to see it someday, that one of them gets perp walked, just one of them. So many of us would like to see that happen. But people can look at. There's so many good pieces of information out there, and look at. You can watch them and you can say, "Yeah, I don't necessarily believe that." That's okay. That's okay. But people should have open mind to the idea that the indoctrination they're getting from the pharmaceutical companies, from big medicine, what I call the medical cartel, is not to be believed, because they've been wrong so many times. It's like trust.
Mm-hmm.
If somebody makes an error in judgment one time, you can maybe forgive them. But if it's a pattern,
fool me once, that's on me. Fool me twice,
shame on you. You're right. Right. I'm saying, but why do you go back and still believe them? Look what they did to us during COVID. You can't go to church, but you can go to your liquor store. Right? You need to stand 6 feet apart unless you're at somebody's elite party in Beverly Hills or in the Hamptons. You have to wear a mask on the hiking trail. We're going to arrest you if you're playing Frisbee on the beach. Okay. Did that make any sense at all? Walmart can stay open, but your local furniture store can't. And we bought it.
I bought it.
I
was afraid
you have to wear a mask at Staples Center, or you have to wear a mask at the airport and the airplane, but you can take it off to eat.
But when you chew it, you have to put it on back.
Yeah, well, I'm just saying, to drink or to take it, it's like, and we all believed him. And the dumbest one of all was the 6 feet apart one. That goes back to I have this exact number rule I think I might have been talking about earlier, mm-hmm. which, like age 35 or 42 weeks or 24 hours of ruptured membranes or 1 minute of delayed cord clamping or 6 feet apart. These are all completely made up numbers, and yet they become part of our culture. Everybody thinks that if you're over 35, that's a problem. No, it's not. No, it's not. It's not a problem in any way, shape, or form just because you're over 35.
But would you say nowadays 34 is like 25? 35 right now is like 25, 70 years ago.
It doesn't even matter, because the number's not going to change, because the number came from the 1950s, that age 35 thing. Came from an era prior to ultrasound where they were doing amniocentesis and there was a risk of miscarriage that equaled the risk of Down syndrome, and therefore that those things crossed at age 35. And it's been kept ever since. It's absolutely meaningless.
What are your thoughts?
I mean, again, look at your labs. If you have diabetes screening, first of all, I'm against the idea of drinking 50 grams of glucose as a universal test, because it's not the way most people eat. What you want to know is how is a woman dealing with her food every day and what's her blood sugar running when she does. So you can check a fasting blood sugar. You can check a 1 hour postprandial after she eats. You could do a hemoglobin A1C and see what her sugars are being. Giving a woman who eats very healthy 50 grams of sugar and then drawing a blood, you have what's called, the test is set to have a lot of false positives. Right? It doesn't, so it has high sensitivity and low specificity. But the test value is 140. So if you're 139, you're fine. But if you're 140, you're diabetic.
Yeah. Okay, so my wife did that 2, 3, 4 weeks ago. I told her not do it.
Yeah,
I know you're healthy. There is no way you have a diabetes. She did it anyways. How can a husband, talk his husband out of it to not do this stupid stuff?
Well, they need to listen to Apollo's podcast.
But she was listening to her gynecologist.
Well,
you have to do it.
I know.
Why?
Again, I was lucky enough to meet your wife and have a brief conversation with her. And I would never try to influence somebody on a personal level. Like my own family, I don't give advice to my family. You know, I'm a home birth advocate. Nobody in my family's had a home birth. I'm a breech advocate. My niece, who's wonderful, who's an OB PA, physician's assistant, chose to have a C-section for her breech baby, even though she knows what I do. So people don't listen to me, and I totally get that. But my feeling is that every pregnant woman, even if they want their obstetrician to be the one that delivers them and they feel safer in a hospital, it may be because they do and they're knowledgeable and they do, or maybe because they're not knowledgeable and they need to learn more. But whatever, you should have a couple prenatal visits during your pregnancy with an independent midwife. Not a midwife that's affiliated with a hospital, not more like a traditional midwife. And just sit with them for an hour, hour and a half, because that's how long your visit will be. Pay them for it. Pay them the $200 or whatever it costs to have a private visit with this person and ask all these questions. And you're going to see a different way of doing things, and you're going to get something that then you can go back to your OB and say, why am I doing this test this way? Mm-hmm. Why are you telling me that this is the only thing that's the only choice? Why can't, with a diabetes screening test, isn't it kind of weird that you're giving me 50 grams of glucose and I weigh 140 pounds and you're giving the same 50 grams of glucose to somebody that weighs 340 pounds?
Correct.
Isn't it weird that I eat green, I'm a vegan, I eat healthy, and you're telling me to take 50 grams of sugar? Does that really tell me whether I'm diabetic and insulin resistant or not? Or should you just see how my body's responding? Let me wear a continuous glucose monitor for 2 weeks if you're really worried about it. By the way, which is kind of fun to do that. I did it this year. I got two-week, so for 30 days, I wore a continuous glucose monitor. And it was really impressive to see what foods really affected me in the wrong way. Like, I love Mexican Coke. But my sugar went up to 180, 190 when I would drink a Mexican Coke. And so I know it's not good for me now.
Mexican Coke, the drink, right? Not the powder.
Not the powder, correct. Mexican Coca-Cola, I should say. Everybody says that. It's so funny when I say that. But no, it's because it has cane sugar in it as opposed to regular Coca-Cola, which has
high fructose syrup.
Yeah, whatever it has. It has the fake high fructose syrup. I think that's right. And then I could see, sometimes I would look at my phone and my sugar would be like 54. I feel perfectly fine, and that's a little bit low. So I sort of modulated myself. It was a good practice for me to do. But to drink that sweet stuff, first of all, read the label. What's in the sweet stuff? It does have high
red
fructose
40,
corn. Yeah,
blue 5, yellow 6.
High fructose corn sugar. That's what it's got in there. So why would you do that? Why not just ask your doctor listen, here's what I eat for breakfast. I have 2 eggs, and I have a piece of bacon, and I have an English muffin. All right, that's a heavy breakfast. Or I have oatmeal and yogurt. All right, or something like that. Why can't I see how my body responds to what I normally eat? Because isn't that more important than how my body responds to some standardized test that is designed for one size fits all? But that's stupid because we're all different.
Let's talk ultrasound. What are your thoughts on ultrasound?
It's overused, first of all. So far,
once or twice is max, not 3-4 times during the pregnancy?
Again, that should be individualized. But unfortunately, like I said, the medicalized birth model doesn't run on individual care. It runs on algorithms. every woman who's got this issue, say she's got twins, say they're non-identical twins, or what are called di twins. Then they're going to have an ultrasound at 10 weeks. They're going to have another one at 14 weeks. They're going to have another one at 18 weeks, 22 weeks, 26 weeks, and then maybe start to have it a little more frequently. There's absolutely no data that supports doing that.
What for?
Well, they're looking for babies that are falling off the growth curve or growth restricted or something else. But there are clinical signs that that's happening.
Okay, but excuse me for interrupting, but let's say you see something during the ultrasound.
Right.
What do you do then?
Well, again,
make
it
an
depends what that
abortion?
something. It depends what that something is. All right. So you're right. Most of the things you aren't going to do anything about anyway, except make the patient worry.
Correct.
And a lot of times you're going to see things that don't mean anything, but you're going to say, "Oh, you know, your baby looks fine, but it had this one little echogenic focus in the heart, which probably in the face of everything else being normal doesn't mean anything. But I want to see you back in 6 weeks to take a look at it." So what's the woman thinking about for 6 weeks?
Cortisol up.
Yeah, there's something wrong with my baby's heart, as opposed to the fact that everything else about the baby was normal. So,
And she can't sleep for those
right.
weeks.
And again, I'm not saying that all ultrasonographers or maternal fetal medicine doctors are nefarious, but there is a profit motive. The more you have her come back, the more money you make.
Charge every time.
Right. Which, if we could change that, we should change that. We should say, you get paid this much for an ultrasound. Any subsequent ultrasound, you only get paid this much. And if you do too many, you got to give money back. You know, I don't know if that's ever going to be possible, but I'm just saying there's got to be a way, and it's got to be financial, to motivate people to do less, because that's how you motivate people. Trying to work on their ethics or their morals it doesn't work in the business world. It just doesn't. So yes, ultrasound is used too often. And the thing about the medicalized birth system is they do not believe that ultrasound has any downsides.
Mm-hmm.
They don't talk about non-ionizing radiation, but I will be honest with you and tell you there has never been a study on humans since the late 80s in China. The ultrasound machines have gotten more powerful.
Mm-hmm.
Nobody has studied the effect of ultrasound and non-ionizing radiation on fetuses. But we know that there's potential for tissue damage and neurologic damage as the neurons are forming from this radiation. And the use of 3D ultrasound to get those cute little pictures.
Correct.
And the color flow Doppler, which I mentioned earlier, which is overused constantly now. It had a narrow mission for babies that were diagnosed with growth restriction on 2D ultrasound to look and see whether or not it's safe to keep the babies going inside or whether it's time to come out, has now creeped to basically being turned on every single time a maternal fetal medicine doctor does an ultrasound. They can turn on the color flow because, as I said, they can bill for that. There's about $100 to $135 upcharge that they can add to their billing every time they turn it on. And that is also a form of high non-ionizing radiation. It's much higher than 2D ultrasound, which is the ultrasound. But again, my colleagues don't think there's any downside to that. And part of the reason they don't think so is because they don't get paid for not doing ultrasound. Imagine how the world would be different if you paid somebody for not giving vitamin K, or not giving hepatitis vaccine, or not doing extra ultrasounds, right? Suddenly there would be indications for not giving vitamin K and not giving hepatitis vaccine. But you can't bill for those. You can't bill for not doing something. You can only bill for doing something. I'll digress for a second. Forgive me. You're allowing me to do this, and I really appreciate it.
Sure.
Let my mind go wherever it goes. When you come to the hospital in labor, they do several things to you, right? First thing they do when you get there is they ask you a bunch of questions about how many stairs you have in your house, what your grandmother died from, how many piercings you have. Why is that relevant to a woman in labor? That's the same questionnaire they'd ask you if you're coming in to have your appendix out, or you come in with a broken arm. It's the same intake questionnaire they ask everybody. Why are you bothering a pregnant woman who's supposed to be in her zone to do that? Mm-hmm. But you have to do that in order to get admitted. Then they send you to the bathroom, where they might send you to the bathroom first to pee in a cup and to put on a hospital gown. Typically, that's what they do at a hospital. I don't know if they did that with your wife, but did she get to wear her own clothes at the hospital? Do you remember?
Oh, the first time when she
was
delivered?
In labor.
Oh, that was like 6 years ago. I don't remember, actually.
Okay. Well, generally,
but that was not here in the U.S. That was in
generally, they'll put you in a hospital gown. Now, first of all, that hospital gown signifies that you're a patient. It's already disempowering.
Correct.
Right. And they have you pee in a cup. Then they're going to draw blood on you. Then they're going to start an IV on you. Then they're going to put the belts on your belly. They're going to do all these things to you. Every one of those things has a billing code.
Excuse me, would you be so kind as to take the...
Oh, my watch off?
Yeah.
Yeah, sorry.
Thank you.
Every one of those things has a billing code.
Really?
Oh, yeah, they can bill for all those things. There's no code for not drawing blood. There's no code for not starting an IV. There's no code for not using their laundry. All right, this is the way hospitals work. They've even come up with codes now for allowing a mom to have her baby skin to skin. They can bill for that.
Say that once again.
There's a billing code now for allowing a baby, for when they put a baby skin to skin, they can bill for that because they have to have a nurse that's standing by. So there's a billing code for that. This is how absurd it's gotten. The reason I'm bringing these things up is because why do you need blood drawn? People will say, well, you got to know what her hemoglobin is. Well, why? She's perfectly healthy. She just walked in. She's fine. If she loses a lot of blood, yeah, you want to know what her hemoglobin is. But you don't really care what she starts with. You're going to treat her symptomatically. If she loses a lot of blood and she's perfectly fine, you're going to leave her alone. You might draw hemoglobin to see what she's at, but you're not going to transfuse her. But if she's unstable, you might transfuse her. So you need to know. But you don't need to know when she walks in the door on every single woman. If she walks in the door and her vital signs are unstable, then you can draw blood based on your clinical findings. But that's not how the hospital works. Hospital doesn't base it on clinical findings. They don't even trust the nurses and the doctors to do that. They have standardized protocols, and everyone has to follow the standardized protocol. If a nurse doesn't do the things that they're told, the nurse will get yelled at on Monday morning. That's what will happen. Then they want to send a blood clot down to the blood bank because just in case you might need a transfusion. We have to be ready. Well, what happens if she came in from the car accident or a gunshot wound? You'd find blood for her right away anyway, O-negative blood or whatever, you'd find it for her. You don't have to send it to the lab. Why do you send it to the lab? Because you can bill for a type and screen, which is what the lab is called. And the reason I say this is because when you go to a home birth, none of those things are done. She doesn't pee in a cup. She's not changed into a hospital gown. She doesn't get an IV started. She doesn't get her blood drawn.
Because she's
and
not
somehow
sick.
she and her baby live.
Yeah.
They survive. It's amazing how that happens. So they do all these things because they've always done them that way. When they cut the cord, they might give you 1 minute of delayed cord clamping because ACOG came up with 1 minute. 1 minute is a fake number. Why 1 minute? Why not 5 minutes? Why not 15 minutes? Well, because they don't want to wait that long. They have to move on to the next task. Leave the baby alone. Let the baby go on mom's chest. Leave the cord alone. Don't touch it. Leave the placenta alone. Wait till the placenta comes out. Then if it gets in the way, you can cut it. But no, they cut the cord. And then what they do in many hospitals, it's starting to change. Skin to skin is becoming the norm now. But in many hospitals, first thing they do is they cut the cord. They show the mom this beautiful thing that she just created. And then they walk it across the room and set it down in the warmer.
Why?
That's a good question. Because of habit. It's the Thomas Paine, one of our founding brilliant people in the United States, said the long habit of not thinking something wrong gives it the superficial appearance of being right. And so if you just do something for a long time, if you ask a nurse why she takes the baby to the warmer, or why is she covering your leg, why are you in lithotomy position in the first place to deliver a baby that's laying on your back with your legs up? It's probably the worst position you can be in. Right? You don't have gravity working for you. You're more likely to tear, that sort of thing. But it's convenient for the physician. You're that position because it's convenient for the practitioner. And then why, for God's sakes, are they covering your legs in blue drapes and maybe even washing off your perineum with betadine, which is that orange sterile stuff? Why are they doing that? It's not like they're going to take out your gallbladder, but they treat birth as if it's a surgical procedure. They're putting drapes on you. It signifies that it's a sterile procedure. Vaginal birth is anything but a sterile procedure. It's not supposed to be a sterile procedure. It's better for the baby if it's not a sterile procedure. It's better for the baby if mom pees and poops on her own baby. Seriously.
Explain that.
Well, because that's where the baby gets colonized with its original microbiome.
Bacteria.
Is mother's bacteria. Mother's bifidobacteria, it's lactobacillus. Those things are the things that you want to colonize your baby's gut, the very first thing. If it's colonized with the wrong bacteria, it may take decades to fix that.
Decades?
Yeah. Yeah. Once bacteria are set up inside of you, it's very hard to get rid of them. And antibiotics, all it does is screw you up even more. Again, it's nature's system Nature designed it to go well. Nature designed a perfect system. Does it always go right? No, of course not. But if you leave it alone for the most part, it's going to do what it's designed to do, and that is to get you a healthy offspring that's going to live a long and healthy life, to grow up, to reproduce, to make more healthy offspring. That's what we're supposed to be doing. All the things that man has done in the 100 years since the Rockefeller and the Flexner report sort of medicalized and pharmaceuticalized medicine have not made us healthier. They've made people incredibly wealthy. But the outcomes belie the fact that it's better medicine. We reached a point where we're doing okay, and then we've gone way beyond that now. We need to get back to common sense and nature's design and the beauty of a woman's body and how it works and how it's designed and how, without thinking about it, that sperm, she can conceive a baby, grow a baby, go into labor, deliver a baby, nurse a baby, heal, all without any thought given to it. It's a normal bodily function. Like you and I breathe and you and I digest food. We don't have to think about it. None of the things that we just talked about with the woman's body does she have to think about. As a matter of fact, when we think about those things, we can screw it up. Mm-hmm. Like, I like this format. I mean, I love here. But some people who've never done this format would come here right now. Their heart would be pounding. They'd be hyperventilating. And they might even be nauseous because their cognitive brain is overriding their primitive brain functions. And if you've ever had to give a speech, if you've ever had to go to court, you can see how your cognitive brain will override your bodily functions and you hyperventilate, you get nervous, you're anxious, you feel that thing. That's not what you're supposed to do when you're in labor. You're supposed to be in a very primitive brain mode. When your cognitive brain is involved, like when you're interrupted and asked questions about your stairs and your tattoos, and you're brought into the cognitive world, it causes your labor to slow down because you're secreting hormones that are anti-mammalian to labor, to natural labor. It's just not what your body's designed to do. It would be like your dog was in labor, say under your bed, and you have 3 little kids, and your little kids are sitting under the bed with the dog staring at it. The dog isn't going to stay there. The dog is going to get up and go someplace else.
You know what's interesting? So when I was a kid, I witnessed twice how my dog gave birth to puppies.
You witnessed it.
I witnessed it. I was
But you didn't
alone.
start. You make a lot of noise.
I just heard something. The noise in the other room, somewhere almost under the table. I was like, "What is going on?" It's like 5 puppies. Like, what?
Right. But if you had been bothering the dog, what would your mother have told you?
Leave her alone. Leave the dog alone.
Leave the dog alone. The dog knows what to do. Why don't we think that humans need to do that? Now, we have higher brains, and having somebody to support us is helpful. I mean, there are people like Michel Odent, who is in his late 80s, early 90s now, I think. He's brilliant. He thinks that laboring women should labor alone, that even the husband shouldn't be there because he thinks it's a distraction. And there's some value to that if you trust truly the mammalian birth. We as a society, I think that it's really bonding for the couple, for the husband to be deeply involved. A man who's with his woman when she's laboring and a man who catches his own baby, with maybe standing right next to them, a midwife standing next to them, I'm going to get emotional here. That man is much more likely to remain loyal and a good father and a good husband and stay with his family than a man who's pushed off to the side, which, by the way, is sort of what happens in the hospital-based model. The man is, in many hospitals, not thought of as important. They're a third wheel.
So they're being left even outside the room.
They're already feeling nervous and scared because they don't know how to support their woman anyway, because men have been poorly educated about what to do. That our movement is doing something to try to bring that, to make men be part of it. But then the hospital itself, we need to take her back for an emergency. You can't come.
What kind of an emergency?
Right.
Why can't I come?
Or we're going to put an epidural in her, sir. You need to step out of the room. Well, why? Why can't I be holding her hand while you're putting an epidural in her? Wouldn't that be better for me and the baby and the mother?
And the mother?
Correct. But nope. Hospital policy says you can't watch us do it. You might faint. You might cough on the field. It's like, Right. Worst case scenario is what they're always expecting the worst case scenario, and they always like to do this thing which I mock, which is called erring on the side of caution. By erring on the side of caution, if you actually break that down, what does it mean? It means you're sort of making errors to be cautious. All right, because being cautious isn't always the smartest way to go. Sometimes there are things that are more important than being absolutely cautious. And how much more inconvenient is it to have a husband sitting there holding his wife's hand while she's getting her epidural? Is it really that bad? Oh, it's a surgery, it's a surgical thing, you're not allowed. Well, it's time to change those rules. Hospitals do these things because they've had these rules, like Thomas Paine said. The long habit of not thinking something stupid or wrong, I added stupid, makes it seem like it's legitimate.
Mm-hmm.
And it's not legitimate. Almost everything the hospital does from the moment you leave your house to go to the hospital in labor till the moment you put the baby in the car seat to drive home, pretty much everything they do is antithetical to nature's design. You name something, and I'll explain why it is. I mean, you could just, I'm not saying we need to play this game, but like people at home who are listening, think about the things that are done to you when you go to the hospital. As we've already talked about, you go into the bathroom, you pee in a cup. You get asked questions in the middle of contractions. You get vaginal exams. For what reason? You get an IV stuck in your arm. You get blood drawn. You get monitors put on you. You get put in a room. You're in a bed in the center of the room. Talked about the bed.
In an uncomfortable
You've
position.
got a little monitor going the whole time. You're hearing this heartbeat. Now, maybe you find that reassuring, but say the baby's heartbeat starts to skip a couple beats, or maybe you move and the heartbeat disappears. Now you're worried there's something wrong with your baby. So maybe that's not necessarily helpful. You don't need to do that. No other mammal is listening to its baby's heartbeat when it's in labor. Every other mammal is in its primitive infant, I forgot the word, primitive brain. That's where it stays.
Not overthinking at all.
It's not thinking.
Mm-hmm.
Period. It's in a state of awe and wonder and on a different plane. It's almost meditative. This is why things like hypnobirthing and meditation and breathing exercises and stuff work. And remember, the gate theory of pain we talked about earlier, if a woman can move, if she can lean on her husband or her partner, if she can get on all fours, if she can do these things where she feels safe. Mammals labor the best where they feel safe. We've already talked about a mammal that doesn't feel safe will get up and move.
Yeah, when I get a stomach pain, for instance, I'm searching for the right position. Maybe on my foreleg, maybe like laying down like this, like that.
Or rubbing your stomach, right?
But not like laying like this and suffering the pain.
And calling for some pain medicine.
Yeah,
right.
It makes sense to leave her alone.
Yeah.
To find to let her find the best position for her. It's individual.
And let's reiterate, by the way, that when that happens, and say you're at a home birth and you're leaving her alone and something doesn't seem right,
correct. Yeah,
it's very rare for something to suddenly go wrong when you've properly been caring for a woman during her pregnancy and properly select her as a good candidate for a home birth, both for the physical things that she has, and also she and her partner have the right mental stuff to have a home birth. If something starts to go wrong, you can see it coming generally from hours away. And you can say to the husband, you take him outside the room and you say, listen, I'm not really liking the fact that she's not progressing as well as we'd like, or that the baby's heart rate's rising a little bit. And if that continues over the next hour, I think it might be reasonable for us to possibly get in the car and go to the hospital. But you don't see that sudden deterioration of fetal status that you hear about in the hospital, where they do all these things to the baby, to the mother and the baby, like we talked about, the hyperstimulation, the epidural, the numbing, the disconnecting that we talked about, and the baby doesn't like it, and the baby's heart rate takes a dive, and they do a crash C-section. They say, thank God you were here, because what would have happened had you been at home, never realizing that stuff doesn't happen at home, because they've never witnessed a woman laboring unfettered. So we need the hospital for the times where you have a problem, like somebody who has an abruption of the placenta at 34 weeks, or placenta previa, or true growth restriction, or diabetes that's out of control, but not diabetes that's well controlled. The risk to a baby that from a mother who's diabetic, whose blood sugars are probably better than yours and mine because she's on it, is probably no different than any other pregnant woman who doesn't have diabetes. Yet all diabetes moms will be thrown into one canister. They'll all be treated exactly the same way. They'll all be told they need the exact same testing. They'll all be told they need to be induced at 38 weeks. Theoretically, if they're type 1 diabetic, they might even need an amnio to prove lung maturity. They'll be induced at 38 weeks. The baby they'll have a protocol at the hospital that says infants of diabetic mothers need to go to the nursery to be observed for 4 to 6 hours, which is, by the way, the dumbest thing that you can do. Best place to observe a newborn baby of any kind, if it's breathing on its own and doing fine, is on the mother's chest, skin to skin, not wrapped like a burrito with a hat on, but skin to skin. You can cover it with a blanket after that if you want to, but that's the best place for a baby to be because we know that mom's skin and mom herself regulates the baby's temperature, breathing, blood sugar, heart rate. All the major vital signs of a baby are regulated by being skin to skin with mom.
Wow.
And yet many hospitals have protocols that say babies it's time for the baby to go to the nursery.
For what?
Exactly. That's what
he's healthy. He's
that's
breathing.
What the partner should ask. And by the way, these are the things you should ask. We said very early on, remember, we said before you're even pregnant.
Mm-hmm.
So the things you go to your hospital and you say, when my baby's born, if my baby is fine, can I just leave it connected to its cord? Can I leave it on my skin? If you need to look at the baby, can you come over here? Can you look at the baby? Can we not rub the baby down? Can we not dry the baby off? Can we not rub off the blood and the schmutz and the vernix off the baby? Can we leave the baby all alone? Ask these questions and see what kind of look you get from the charge nurse or from your doctor. If they look at you and give you the time of day and they have a conversation, that's great. That's a good doctor. If they roll their eyes or if they huff or if they can't wait to get out of the room, that should be a huge red flag that tells you this is not the practice for me. This is the most important thing you could ever do, is give your baby a good start in life.
Correct.
That's tied. There's a lot of things tied with that, but that's certainly one of the top ones.
What about the umbilical cord? Should I keep the cord up to 30 minutes till it's pulsating, right?
Yeah, you should. The cord should pulsate for as long as it pulsates. As long as, again, there's always exceptions, but in general rule, baby is just getting its blood back that it was squeezed out of it when it came through the vagina. Mm-hmm. And in that blood, not only is its hemoglobin and well oxygenated blood with nutrients from mom because it's still circulating and mom is still breathing for that baby. And while that baby's transitioning to lungs for the first time, mm-hmm. it's still getting oxygen the old fashioned way, coming through the cord, mm-hmm. and as are nutrients. And so what is the point to cut it off? In no other species does anyone rush in and cut the cord. Yes, in an elephant that falls to the ground, the cord snaps. Okay?
But it's like 6 feet tall.
Yeah, that happens. But nobody rushes in to cut the cord of a deer that's born or a cow that's born or anything like that, unless they let it rip itself. And by the way, if the cord does snap, we grab for a clamp and put a clamp on the cord. That's smart, but ultimately that baby would not exsanguinate. That cord will eventually spasm, and that bleeding will stop because all other mammals, their cords do snap generally, mm-hmm. and they don't bleed to death. But we're afraid to let that, nobody wants to watch that happen. But leave the cord alone because that's what nature designed. When the placenta comes out, or for some reason the mom is unstable and you need to move the baby off the field, then clamp the cord, give the baby to dad. Have the dad take his shirt off, give the baby to dad, have dad hold the baby chest to chest.
Skin to skin.
Yeah.
It's crucial.
Why not? Why not? Baby's being colonized by dad's bacteria, mom's bacteria. You don't want it to be colonized by the bacteria that's on the warmer over in the other corner.
Because skin is the biggest organ, right?
Our skin is our biggest organ, yeah, right. Bigger than the liver. Liver's second, but the skin. Nobody thinks of skin as an organ. Mm-hmm. But otherwise, leave it alone. When the placenta comes out, if they're having this wonderful time with their baby, don't try to sneak in there with your cord clamps and cut the cord so you put the clamp on the baby. Leave it alone. Put the placenta in a Ziploc bag or a bowl. Leave it on the side of the bed and leave the parents alone. Come back later. You say, you know what? It's time to take a look at your baby and stuff like that. Or mom needs to get up to go pee or something like that. Okay, now let's cut the cord. Let's make it, we'll cut 2 clamps. Dad gets the scissors. Mom gets the scissors. Somebody cuts the cord. Maybe big sibling gets the scissors at home. The big sibling gets to generally cut the cord. They think it's the greatest thing ever, right? Something that, because they don't usually allow siblings in the hospital rooms.
Correct.
Right. At home, it changes that sibling's take on birth for the rest of their life. Something we also forget is that, we've sterilized birth from the family, just like we've basically sterilized death too. 100 years ago, Apollo, people were born and died in their own home, their own bedroom. People saw Granny grow old and die. They stood by her, held her hand, kissed her. COVID was the worst. We saw these people die alone. Right. And they saw their siblings being born. They saw mom do it. And mom did it because she saw her mom do it.
That's life cycle.
Right. Right. Medicine is a business. They want your business. They're going to constantly make it seem like these things are dangerous. They're not more dangerous than the hospital itself. The hospital is filled with babies in the NICU that came into labor and delivery inside their mom in perfect condition. And somehow, during the process of being in the hospital, being induced, ended up in fetal distress with an emergency C-section and had to go to the NICU. And they think that that's normal. They think that that's fine. But if a baby comes from home and ends up in the NICU, oh my God, that's terrible.
Correct.
That stupid woman,
Double standards.
that irresponsible midwife. But if the same thing happens in the hospital, we did everything we could. It's like, no, you caused the problem, then you solve the problem, and you want to be patted on the back for solving the problem that you caused. It's so obvious if people would just take a step out of their, their hamster wheel and take a look at what actually is going on. And we need to break the silos. We need to have home birth midwives spend time in labor and delivery. We need OB residents and nurses to come and spend time at a home birth. Come and be a fly on the wall, sit in the corner of a home birth and watch. You'll be bored out of your mind. Those hours where you're doing absolutely nothing. You're sitting. I used to lay on the couch with my headphones in, listen to my classical music, is the way I sort of dealt with the fact that I'm doing nothing. Because when I was a resident or a doctor, I wasn't in the hospital laboring with my patient. The nurses called me when she's ready to push, and then I would drive over to the hospital and I would help catch the baby. I never watched the laboring part. And I would get impatient. And they would say, what's she doing? And that would force the midwife, the nurse to do a vaginal exam, which was unnecessary. Just leave them alone. There isn't any timeline that has to be universal. Yet hospitals, again, they run on algorithms. They're like hotels. They need to move people in. They need to move people out. You can't be sitting there for a couple of days. And then there's the stupidity of the system too. They'll tell a woman who comes to the office at say 40 weeks and 4 days, and they'll say, your fluid is low. Your baby's in trouble. I think we should induce you. So the baby's in so much trouble that they'll bring them in for an induction, which takes 3 days.
Mm-hmm.
If your baby's in so much trouble, then how could you take 3 days to induce them? Why didn't you just leave her alone for 3 days? And maybe she would have gone into labor on her own. Nope. We got to induce them because, again, there's no billing code for leaving a woman alone at home. And I know that this sounds like, I'm not trying to ruin everything I'm saying with the cynicism, but I'm telling you, this is born of living in both worlds for a long time and seeing the motivation. And the only other, if it isn't a financial motivation, then it's idiocy. And I don't want to attribute idiocy or evil to my colleagues. So it has to be, my cognitive dissonance is saying to myself that it has to be financially motivated because my colleagues aren't idiots.
But then
my colleagues aren't
sellouts. It means they're sellouts.
Well, they have their own issues with that. They have to figure out why they do what they do.
Okay, what about that stuff in Kenya that they did? What, was that evil, money-driven?
That's evil.
So they hate humanity, or they hate the blacks specifically because they were doing this in Africa, not the.
I think purposely that was purposely a thing for anti-Africa to slow the population growth in Africa. Again, people need to watch.
Huge continent.
People need to watch the documentary. Well, I think if there was an experiment, if they got away with it there, they might have done it more universally. I don't know.
Yeah, I believe what we know is like the tip of the iceberg.
All I know is that when something doesn't smell right and you look into it for long enough, you're going to find something nefarious behind it. And you'll see that with your example of Ozempic. All right. Ozempic seems like a miracle drug. It's horrible. It's causing all kinds of problems. Just listen to the commercial for Ozempic. Listen to the 20 or 30 seconds of side effects. You know what I'm talking about? Bloody diarrhea, blindness,
Kidney
seizures,
damage.
kidney damage, right?
Liver damage.
Yeah. And then the last 10 seconds, it's like, take Ozempic. Ask your doctor about it. It's the greatest thing ever. It's like, wait a minute. I just listened to that commercial properly? That's why one of the things that I hope RFK Jr. does, because the United States and New Zealand are the only two countries in the world that have direct-to-consumer advertising in pharma. Because pharmaceutical advertising on television is essentially money laundering. It's a way a pharmaceutical company can influence a television network and get their news divisions to not publish bad stories about them. Because if 60% of their television, of the revenue running that network comes from pharmaceutical advertising.
It comes with it.
Right. You take away that advertising and suddenly networks have to figure out another way to survive, and they can then publish stories on anything about pharma. But right now, nobody watches a commercial for a drug you can't pronounce and goes to their doctor and says, I want that drug that I can't pronounce so I can play tennis again with my partner. All right. I saw that commercial on TV for that drug I can't pronounce. And by the way, you notice how the drugs always have names that they're missing too many vowels and they can't pronounce them. If you watch the TV commercials, why not name a drug something that people can remember? It's all made up.
Well, they can remember Tylenol, aspirin.
But that's not the drugs they're advertising.
Oh, yeah.
Vabrismo, I can't even think of the names.
Yeah.
Even Ozempic. What's up with it? What does that mean? What does that have to do with losing weight?
You see, in my opinion, the biggest problem with Ozempic is the same as with having a prostitute for sex or drugs for having a better mood. You don't deserve it. You deserve a fit body and strong health by working out and eating right, but not by getting this shot.
Yeah. Well, it's a quick fix. It's kind of like I just did a podcast with somebody who does restorative reproductive medicine, which is for women with fertility issues. Instead of just directing them directly to IVF, which is a multi-billion-dollar industry, what they try to do is they try to find the underlying root cause and try to fix that, which makes more sense. And a lot of it is nutritional. Some of it is surgical for endometriosis. Some of it is lifestyle changes and other things like that. But they try to fix the root cause. And what I analogize that to is the old saying that if you give someone a fish, they eat for a day.
Mm-hmm.
If you teach them how to fish, they'll eat for the rest of their life. So if you give someone IVF, they have a 35% chance of getting pregnant that cycle. But next cycle, they have a 0% chance of getting pregnant.
Why?
Because they're not having IVF.
Oh, okay.
IVF gives you that
Gotcha.
one cycle, one chance. And I'll relate it to what you were saying in a second about those other drugs. But if you fix the underlying problem and you make her fertile and you make her ovulatory every month again, then she has a chance to get pregnant every given month. And one's a lot cheaper than the other one, and one gives you a better chance of getting pregnant over time than the other one. Now, the argument against it is, well, you're going to delay it, and she's older, and if you delay it, she might not be able to get pregnant, and then you've made IVF less likely. And yes, there's arguments for that, but at least you should inform the woman of the different choices. But if you fix her underlying problem, she doesn't need IVF, and she can then feed herself for the rest of her life.
Yeah, but she has to change her diet, to work out, to see the sunlight, maybe to stick
Or to correct her
her
thyroid,
legs
or just correct her
to the
thyroid, or do
grass.
whatever it is that's underlying the reason that she's not either ovulating or getting pregnant. Solve those problems. So it gets back to your quick fix with Ozempic and other things like that. You know, you're giving them a fish rather than teaching them how to fish.
And the fish is poisonous.
And the fish is poisonous, by the way. That's actually a good point. It's got, yeah, because you're filling them with toxins. Ozempic is going to destroy their liver. It's going to destroy their kidneys. It's going to destroy other parts of the body because it's not meant to. Your body is not meant to not handle fatty acids and other things like this thing is blocking. It's blocking some sort of, I don't know the mechanism. I've never really looked into it, but it's blocking something.
Do you think those celebrities are really using Ozempic?
Some of them, sure.
They're that stupid?
Yeah. Oh, yeah.
Oh, really?
Oh, yeah.
They have all the money in
No,
the world.
they're that desperate. They're that desperate to.
They can buy the best food in the world. They're millionaires.
Yeah, they can have liposuction too. They can have Botox and other
And
things.
it doesn't take much. It's like 30 to 45 minutes a day of a workout. That's it.
No, but
Not hours upon hours.
But you bring up a good point. I can tell you that there was a huge con with the COVID vaccine. They would show celebrities and politicians getting the COVID vaccine on television, and then they would they would roll down their sleeve and get up and walk away. And they even showed Joe Biden doing that, bumbling, stumbling Joe Biden. Right now, Joe Biden, they were worried about falling down at any given time. But if you, as a 30-year-old, went to CVS to get a COVID vaccine, what did they have you do after the COVID vaccine? They had you sit there for 15 minutes. There was a rule. You had to sit there for 15 minutes and wait to see if you had a reaction. So when you saw a celebrity or when you saw a politician get a COVID vaccine and then get up and walk away, you can be damn sure that that was either one of those movie fake needles or they were getting an injection of saline. Because there's no way they would let somebody as unstable as an old person like Nancy Pelosi or Joe Biden or Chuck Schumer stand up immediately after they got a COVID vaccine. You saw how many times that people were talking and they fainted on the news camera, or they fainted, they fell to the ground, stuff like that. They didn't want that happening to one of their politicians.
Normal.
Right. So you know that they couldn't possibly. So again, it's all propaganda. People have to understand there's huge, huge, huge money behind all these things. And whether we stick to obstetrics itself or we go to other medical issues like that, the SSRI issue, the statin issue. I mean, one of my best friends is an internist and he believes in statins, and we have this conversation, and we've sort of given up on having this conversation anymore. I think that statins are one of the worst drugs ever created. And and partly because I believe that cholesterol has a very vital role, and partly because I believe that the levels of cholesterol that they said were abnormal were just created out of thin air. They're more fake numbers. And partly because you're seeing people that take statins for a long time, they're unable to myelinate their nerves or correct problems, and they're probably having more evidence of dementia and other things coming on faster. So, but trying to get doctors who've made a living off of prescribing statins to people to suddenly say, geez, I've been doing the wrong thing.
No,
that's really hard to do. It's very hard for a doctor who wants to do good to think that they're doing something wrong. Same thing goes with the SSRIs. The theory of serotonin reuptake as being a cause of depression is probably incorrect. Yet it's been the basis for 30 years of the Prozac and related drug industry. Another billions and billions of dollars of industry. They're not suddenly going to let it go, and they're not going to take responsibility for it, because to say that they were wrong opens up the floodgate for class action lawsuits and things like that.
Well, two things. Life is not possible without cholesterol, right?
Correct.
Cholesterol brings all types of nutrition.
It carries other things in your bloodstream.
Oxygen.
And it's the building block of many of the proteins and other structures in your body. Correct.
So the second thing, Oxycontin, you can still buy Oxycontin in the pharmacy, right?
That I don't know. I just watched that. I finally watched that documentary called
Painkillers?
No, it was.
I read the book about the Sackler family.
There was a docudrama with Michael Keaton in it. I can't remember the name of it, but it was about the OxyContin thing, about the Sackler family.
Yes.
Yeah, I watched that, and I mean, I don't know if it's still a drug that's even available anymore.
But it's the family was nefarious, right? Can you still buy?
Oh yeah, they paid a big fine, but they had so much money. It was like you and me paying, like, you and I could, if we got fined $1,000, we'd pay it. All right, it wouldn't really affect our life anymore.
Correct. Nobody went to jail, right?
Nobody went to jail.
Yes, Oxycontin is still available by prescription in the United States, though under the tight regulation as a Schedule II controlled substance. So you can still buy it. It was proven that it causes addiction. How many people died from opioid addiction? 100,000?
Yeah, you're outside my expertise now, but I'm a layperson on that. But yeah, Hundreds of thousands of people died. And lives were destroyed, families were destroyed, children were destroyed. Yeah. And all because, and we know from whistleblowers and things like that, that the whole advertising campaign about that stuff was all propaganda, all a lie. And that again, you have to realize that was the same thing that happened with formula, breast formula, milk formula. We were told. I can remember in the 80s and 90s of these drug reps coming to our office, bringing us really nice lunches, taking us to Laker games, giving us these really nice gift bags with formula in it, telling us that formula was better than breastfeeding. And we used to have, Apollo, you're going to shake your head even more now. We used to have standing orders on our postpartum when I was a resident at Cedars. This would be the early 80s. There was a standing order to give a shot of something called Thalidomide or Del-estrogen, which were two estrogen-containing compounds, to give to a woman who just gave birth in order to dry up their breast milk so that they could bottle feed without getting engorged. So
dry up the breast milk?
Right, because we encouraged bottle feeding because that's what we were told was good. Right. You know, if I was one of those devout Christians, I would get one of those things and start flailing my back, you know, for the things that I didn't know, but I did when I was young. Right. So we encourage women to not breastfeed. That was the medicalized model. And it was all pushed by Big Pharma. It was all a lie. Birth control pills, another monstrous lie. Birth control pills, you'll be free, as if the menstrual cycle and a woman normal cycling doesn't have benefit for her body. We're just going to shut it off for 20 years.
We know.
And now you're 35 and you want to try to get pregnant, you get off the pill, and now you've got all kinds of problems that we're masking. We've been masking for all these years. You know, women get on the pill when they're 15 or 16 because their periods are too heavy or they're too painful or they've got acne, and they just put them on the pill rather than trying to solve the underlying problem. They put them on the pill, and then they've obliterated the need to look for those things. But those underlying problems are still there, and they're festering for the next 15 or 20 years. And now you get off the pill and you want to have a baby, and now you got all kinds of problems. And what has the pill been doing to your body when you've not been cycling every month? Not getting to know your body, not getting to know your fertile mucus, your not to value your menstrual period as opposed to think of it as a curse. You know, that nickname that's given to it, it's the curse. You know, that's horrible. And I think men did that to women.
100%.
Right.
Just to have promiscuous sex and not having kids on the side.
Yeah, I mean, I'm not gonna ascribe motives to it, but I'm saying that terminology like that.
Of course.
Yeah, she's on the rag. Think about that. She's on the rag. Her mood. She's moody because she's on her period, and the rag is essentially like a pad that she's wearing. But the body needs to do that. There's something your body is designed. Again, if you think about nature as a perfect design. Sometimes it doesn't go awry, but the normal bodily functions, think about how miraculous it is that I'm looking at you right now, that I'm breathing, that I'm smelling the smells, that I can sense my skin touching the chair or my pants or whatever, that I can breathe, and that I'm digesting my very tiny breakfast from this morning, that I can do all those things without ever having to think about it. It's a miraculous thing. And the menstrual cycle is just like that. A menstrual cycle is part of a woman's body, and we're suddenly shutting it off and saying that this is as good as nature. This is better than nature. Oh man, the hubris of man.
So there is no male pill, right? Birth control for male.
No, not that I know of. They were coming out with one.
Do you think male would have taken those pills if they would have messed their hormone system?
No, of course not.
Never.
No.
These are my hormones, right? Testosterone and all others.
No, men are even reluctant to get vasectomies.
Correct.
For whatever reason. And vasectomy is, we did a podcast on vasectomy and tubal ligation. And, I mean, they're both meant to be permanent sterilization. Vasectomy is an outpatient procedure done in a doctor's office. Tubal ligation is an operative procedure done laparoscopically in a hospital. It's much easier for a man to get a vasectomy. Now, there are side effects to tubal ligation and there are side effects to vasectomy. But most men it makes them squeamish. Men are squeamish about that. Just anybody touching down.
Of course, don't touch my balls. That's
Don't
it.
touch my junk, right?
Correct.
Leave it alone. So yeah, men don't do that, but we expect women to just jump on it. And we sold it. We sold it to them as freedom.
Freedom. That's freedom.
Freedom.
That's like abortion. That's
Freedom.
That's freedom.
Yep. The American College of OBGYN has agendas that I think are misguided at best and probably financially motivated at worst. And one of them is that things like the birth control pill are the greatest thing ever. And that they've even put out memes in the past year on their Instagram account that talk about, oh, you're going on vacation? You don't need to have your period. Oh, if your period bothers you, you can take birth control pills continuously and not have a period. It's like, yeah, these are the experts in OBGYN telling you that you don't need these things and that you can do these things. And I rail against the American College of OBGYN. I think their new president is an ideologue beyond reason. His name's Stuart Fischbein, and he is constantly putting out blurbs about, that he thinks that Robert Kennedy having a panel discussion about SSRIs in pregnancy and having only one person on that panel that is pro-SSRI in pregnancy, even though, as I told you before, there's never been any data or safety studies done on pregnant women with SSRIs. He thinks that's abomination. He thinks that Robert Kennedy is a bad guy. They're all into on vaccines. They still think that pregnant women should get the COVID vaccine. And that if you counsel a pregnant woman about the COVID vaccine or about the pertussis vaccine, and they choose not to get it, which is, by the way, a very ethical choice of a woman to take the counseling and then choose to not do it, he thinks that it's the doctor's fault, that they must have counseled you wrong. Because if you counsel them the right way, then they will obviously do what you tell them to do. That is coercion, and he's the chairman he's the head of ACOG now, and he's unabashedly unashamed of, if that's a proper use of English, of saying these things. It's incredible what he seems to want to promote. He believes he believes in the medical system and believes in the medical model, and
it's
clearly has not taken a look at outcomes. Somebody like him would be great to get on a podcast with somebody like me, or on
They would never do that.
No, they won't do it. Which is what I'm saying. To sit in an auditorium with 300 people in it with a moderator,
doing Q&A,
and he's got a lot more credentials than I do. And I would sit in a chair right next to him. I'd shake his hand, and I would bet we would find that 70 or 80% of things we agree on 100%. But the other 20 or 30%, I would be willing to bet you that he's never even looked at things in a different way. Because again, these people aren't stupid.
Of course they're not. But if your idea is so good, you should be able to debate on that idea.
That's correct.
If you think that your idea is the best, that communism is the best, let's debate.
Right, but they won't.
They will never do it.
This is one of those things that I've said before, and I'm hoping that will change with the new Trump. But in the old Trump, early in COVID, if he had said to Anthony Fauci and Deborah Birx, the two biggest protagonists of the COVID vaccine and the anti-hydroxychloroquine or ivermectin stuff, and the whole lies about the lab leak theory and all that stuff, if he would have had them on the stage and he would have said to them, hey, Anthony, I booked 2 hours of primetime network time, and you and Deborah are going to go on and you're going to speak to Peter McCullough and to Jay Bhattacharya. And we're going to have a debate moderated by Brett Baer from Fox News or Dana Bash from CNN or whatever.
And
it doesn't matter.
And if you don't do it, you resign.
Correct. Right. Why wouldn't you do that as president of the United States? Because I really think he got duped as well.
Operation Warp Speed.
Yeah, I think he got duped by he trusted his medical advisors. Trump doesn't know shit about.
Yeah, he's not a doctor.
Right. He doesn't know. Well, doctors don't know shit about it either. He's not a researcher or a scientist or an expert in that. He has to trust the people that are around him. And he got really bamboozled and misled. And I think to this day he regrets it. He should come out and say it. He should come out and do a mea culpa and apologize to the American people.
He will never do it.
No, of course not.
The ego is too big.
You know what? He might.
No.
But most of these guys would never do that. But that's what I would do. And if the next time there's a big controversy about something, this is what our leaders should do. They should buy 2 hours of primetime television. By the way, if they take away Big Pharma as an advertiser, the primetime television networks will be waiting to eat that up because they need the revenue.
Right.
And people will watch that. You would have watched that. I think they would have had 100 million people watching a debate between Fauci and
Do it on
Peter.
pay-per-view. I'm going to pay like $12 bucks, $20 for that.
Yeah.
I would pay him.
Yeah, it should be free though. It should be free. It's your tax dollar.
But people even would have paid 100%. Answer me this. One of the last questions that I have. They can invent a vaccine for, let's say, from COVID, right? Why not? Why don't they invent a cure, a pill for that? Once I get it, I take the pill and I heal up. Why not?
Well, they have them, but they're called ivermectin and hydroxychloroquine and zinc and quercetin and
Mic drop.
yeah, they have them. They can't make money off of them. And by the way, it brings up the point that you said. It's the same thing if you think of obstetrics. It's like if something really is honest and truthful, people will follow it and people will go for it. If you have to mandate it,
It's so good.
by definition, there's something wrong. There's something wrong if you have to mandate it.
I would have mandated beef every day and eggs every day.
I wouldn't mandate that either. I'm a believer if people want to be fat and lazy and have heart disease, that's fine. And you know what? And again, I don't believe that. I mean, I believe we should have a social welfare network that should take care of people. And you can't say to them, "Well, if this is self-inflicted injury, you can't get help." I mean, the thing is to encourage them through education and motivation, and maybe even financial motivation, saying, if your BMI is under 24, you get a $1,000 tax credit.
Ooh.
Okay? Right. Why not? Because that's what motivates people. Again, it gets back to that simple, I learned this in Basic Economics 101. I didn't need Milton Friedman or Tom Sowell, two of my favorite guys, to teach me that if you tax something, you get less of it. If you subsidize something, you get more of it. So incentivize people to be healthy.
Yeah, but this would unload the hospitals, so they would earn less money. Bad.
Well, hospitals should have to streamline themselves. And again, this is a dilemma because it's true because we need hospitals for those major surgeries, those things that really help. The open
100%.
heart surgery, if you really needed it. The liver transplant, the kidney transplant, if you really needed it. If you have a placenta previa and you need a C-section, if you're bleeding to death and you need a hysterectomy for that. Those kind of things, we need to have those available. And the only way the hospitals can stay open and keep their doors open financially is to have all the other shit that they don't really need to have or do, but they preach to us as if they're necessary. Pregnancy is the only thing you go to a hospital for something that's not when you're not sick. There's nothing else. Think about it. There's nothing else you go to the hospital for a normal bodily function. You don't go to the hospital to digest your dinner. You don't go to the hospital I don't know. You only go to the hospital to be admitted. You might go there for diagnostic testing because in their outpatient services. I'm talking about getting admitted to a hospital. There's nothing else you go to the hospital for other than pregnancy, where you're actually well. Pregnancy is the only thing that's normal. It's normal function of your body, and yet we do it in the hospital. And we did that because back in the 1920s, they vilified midwives, naturopaths, homeopathy. They took away everything, and they took over the medical schools, and they made it pharmaceutical based, and they made hospitals the key because there were people that were making huge amounts of money on that. And we've got to stop thinking that that's the best way to do something that's not an illness. To treat something that's not an illness. It's a normal function. And when it goes awry, just like if your digestion and you suddenly get bloody diarrhea or colitis or intractable vomiting, yeah, you need to go to the hospital. But you don't need to go to the hospital every time you eat steak because you might choke on a piece of meat. That's not how we should do it. And it's the same thing for pregnancy. And again, because I'm experienced in this world, I've seen it, that things rarely go wrong suddenly. And your outcomes from home birth are better in every category with similar cohorts of women, whether they're low risk or what are theoretically called high risk, which I hate that term, as you know, you're better off being at home for most things because your outcomes will be better. They'll say, well, you might have a bad outcome at home. Yes, you might. Because there's no zero risk probability when a sperm and egg come together. But you're more likely to have a bad outcome with similar cohort of people in the hospital. You're more likely to end up with an induction, an episiotomy, a forceps or a vacuum delivery, a cesarean section, or a baby in the NICU, and emotionally traumatized by being in the hospital and being at home. Home birth isn't for everybody, but informed decision making is really our right and is. And so we should give this information. We shouldn't stop bullying and vilifying women who choose to have an out-of-hospital birth. We should make it as a reasonable option. We should then train. We should have traditional midwives training more traditional midwives so we have more personnel who can do this. We should reimburse differently. We should insurance, if we're going to stick with the insurance system, which has got its own flaws, if we stick with the insurance should cover home birth. I don't know why they don't. It's a lot cheaper than hospital birth, but for whatever reason, they're in cahoots with hospitals and doctors and stuff, and they just don't seem to want to cover. You know who does cover it really well is the health sharing ministries. They're not insurance companies. There's these things like Health Share and Christian Ministries, and they're like groups of people that come together that help each other out. And so if you have a hospital bill, you submit it to the health sharing ministry, and then everyone sends you a check for $100, and you get enough money to cover your bills. There's very little overhead in that. There's not. Those ministries don't have beautiful buildings and private jets, okay, and CEOs that are making $5-10 million a year. You know, they're very close to the budget. They're much more human. They're more like the old co-ops of old, where farmers used to get together, and when Farmer Jones's crop failed, Farmer Brown and Farmer Smith would bail out Farmer Jones. All right, that's what would happen. That's what we need to get back to.
Amen.
But we need to, and so we need to change the way we reimburse, and we need to change the primary caregiver of pregnancy should be a midwife, and not a medicalized midwife. It should be a traditional midwife. They're the ones that are experts in normal birthing. Doctors are experts in problem birthing. Therefore, they see problems everywhere they look, but they don't know anything about normal birthing.
Yeah, they're problem solvers, which is good. If there is a problem, I need a doctor.
Yes.
But if there is no problem,
don't
solve it.
Yeah, you don't need a doctor. You know, there was I think it was Marcin Wagner. He's passed away. He was another mentor of mine. He was an obstetrician. He said something to the effect that having an obstetrician at your normal birth is like having a pediatric neurosurgeon babysit your 2-year-old. Okay, it's overkill.
Yeah, overkill.
You're overqualified.
It's too much. Correct.
You're overqualified to be sitting there at a normal birth as an obstetrician, but you have to do it because that's where your revenue comes from. Because you wouldn't make enough revenue just taking care of the high-risk moms. So you have to take care of the low-risk moms, but then you don't take care of them as low-risk moms. You fit them into the model of care that you've been practicing all your life and that you were trained at in your residency and indoctrinated into, and you see everything as a problem, which gets back to that whole thing I said earlier about, do you have any other medical problems, right? Pregnancy is not a problem. It's a normal function of the body. And if we need to get back to that, and women, you need to seek out midwifery consults with traditional midwives. We need to encourage more young people. We need to get to young people when they're in middle school and high school and teach them about the normal function of their body. And I'm not just talking about young girls. I'm talking about young boys as well. So they can learn. You know, they don't need to learn how to put a condom on a banana. I mean, they can learn that too, but that's not hard. But they really need to learn about the physiology of the menstrual cycle and how normal it is and how beneficial it is. And it's not something dirty, and it's not something to be giggled about or laughed about.
Correct.
And it's something you should be able to talk to your children about. And these 15, 16-year-old girls should be able to talk to their mothers about that and their grandmothers about that. And their grandmothers shouldn't be embarrassed to talk about it with them. But culturally, there's been 100 years of women trying to hide these normal functions of their body because they're dirty. And they're not. They're beautiful and they're normal. And if we just start to think about these, we can change the next generation and the future generations for the better rather than for what we're doing now, which is every generation seems to be getting sicker and worse and more fearful.
Doc, so I have the same question every time I have a podcast. So the last question remains always the same. Let's have two assumptions with you. Assumption number one is the President of the United States of America is the most powerful human being on planet Earth. Assumption number two is you become one. You become the President of the US. Once you do so, you have all these three-letter agencies, Secret Service, everything at your disposal, right? So they come to you and say, congratulations, Dr. Sue, you're now the President of the US, and now you have the access to all the information in the world. You ask us, we give you an honest answer. What would be your first question?
Wow, you pulled this out of left field for me. So my first question, I have a lot of first questions.
I know. That's why the first one is the most important.
I think because I grew up with that era, I'd want to know, did we really land on the moon?
Let's say they give you an answer that was fake. You as a president of the US, would you expose it to the public?
Yes.
You're not afraid of the chaos that it may bring?
No.
At all?
No.
So people can handle the truth? Whatever it may be?
Yes. People need to, yeah, because the alternative is worse. Thinking that my fellow citizens are sheep and can't handle that is worse. And by the way, the lies always eventually come out anyway. Yeah, I'm not for protecting the soft temperament of people. You know, I want to know, you know, what the CIA was up to. I would expose that sort of thing. That's why I would never live to be president, because I would want to do those things. I would certainly make changes because of my interest. I would make changes in the medical world. You know, I'm a big supporter of what Bobby Kennedy's trying to do, but he's dealing with incredible forces pushing back on him. So he can make small changes at a time.
Which is good. Small change is better than no change.
Small change, yes. Small change in the right direction is better than no change. You know, I wish I had a better answer for you.
No, that's a good answer.
There are certain people I would love to be able to sit in my life and talk to. You know, I mean, some of them are still alive. Like, I would love to have coffee with Christopher Nolan.
Oh, yeah.
Right. And
he doesn't even have a cell phone. Do you know that?
No, I didn't.
He doesn't even have a smartphone.
No, he just makes some of the movies that have moved me the most in the last 20 years of my life. You know, there are certain famous people. I won't get through but there are famous people, or even not so famous people, that I would love to be able to sit down and have a conversation to, and I could invite them to the White House, and they could stay in the Lincoln bedroom, and I could have breakfast with them, and I could do that. That would be great. So yeah, I would want to get back to basics. I would want to get back to truth. I would want to expose people who are liars, frauds, who have profited off of the system. I would ask Nancy Pelosi how she became a billionaire. Those are the kind of things I'd want to know. And do I want to see perp walks and things like that? That's not even the point. Point is, what's done is done.
But no more.
But I'd like to see it, be able to know what was done, so we can prevent that from happening now. I don't know that you can. I mean, the idea that money is all corrupting is pretty true. Pretty much, you know, there's the old saying that everything has a price.
Mm-hmm. And everybody.
Everybody can be bought. And it's probably true to some extent. I don't know that somebody gave me $1 million if I started promoting C-section for breech.
Oh, no, they don't. I believe they don't operate in millions. Let's say 100 million. 100 billion in 10 years.
For me to just change, I don't think I would do it, because I don't know that my life would, I mean, what do I need more in my life right now?
Okay.
Right. I mean, I like mowing my own lawn. Okay.
There's something into it.
I like gardening. I like cleaning my own pool. I mean, I have a pool. I'm thrilled. I have a swimming pool. I don't need. Would I love a private plane? Yeah, I'd love a private plane. Okay, that would be fun. And I'd like to fly it myself. I was a pilot for 10 years. I had a small private pilot's license and flew out of Santa Monica Airport for 10 years. And that was just fun for me to do that. It was adventurous, adrenaline rushing, but also I had to rely on myself. And when I was flying my plane, nothing else mattered. So if I had problems at home or if I had problems at work, when I'm flying my plane,
They stayed on the ground.
well, no, you were focusing on flying.
Yeah.
Especially a little plane like that, which really didn't, you don't just push a button and go on autopilot. You had to fly the thing. So I don't know. I wish I would have known this ahead of time, and I would have come up with some.
No, that's a good.
I would have come up with some brilliant answer, because in my mind there's something really brilliant. But I really think that I'm in the last third of my life, and I think that I really want to make life better for my children and my grandchildren. I think that most people do, and yet some people are so sinister. They only think about themselves. They don't think about the long-term good. I mean, they're pushing vaccines on people. Are they really vaccinating their grandchildren? Are they?
I don't think.
I don't think so either. They want open borders, but are they letting the people come into their neighborhood or live in their backyard? No, of course not. I don't want our country to be like that. I want this to be a place where people feel safe and where children feel safe. I'd like to see us get back to traditional family. I'm divorced, but I'm very close with my ex-wife, and I'm close with my family. In fact, I'm here in LA visiting. I'm staying at my ex-wife's house. I'm visiting my kids and hanging out. And I think that is something that has great value for me. My kids know that I'm a sap. I cry at pretty much every Pixar movie, pretty much. And because there's a sweetness and a lesson in life, and too many people go without that. They're broken families. They're surrounded by violence
and loneliness, especially after 2020.
Loneliness is a huge thing, and the cell phones and the gaming have made that so much worse. Social media has gone, the lockdowns, the Zoom meetings. You, my friend, right, made me come to Los Angeles to be interviewed.
I told you right away, I'm not doing Zoom.
Not doing Zoom.
Can't stand it.
Right.
We would have never had this amazing conversation. 3-hour conversation flew like this. We would have never had this conversation via Zoom.
No, it's been 3 hours.
Yeah, 3 hours and 11 minutes.
What's amazing about that is I listen to Joe Rogan sometimes. I can never make it through the whole thing. He does this, 5 days a week?
Oh, yeah.
Yeah. I mean, you do it, what, once a week or something like that?
In 5 days.
Yeah,
like
okay. So it's amazing that he can do that. But you're right. When you're sitting across the table from someone, it's like having coffee, and you can have this conversation. I used to think when I was dating, and you go out on a date with somebody, and suddenly and you'd been sitting there, and suddenly 3 hours have gone by. You knew that was a woman that was worth keeping. Whereas there were some dates that, an hour and 15 minutes. It's like, yeah. But sometimes I'd be on a date, and I'd be talking to somebody, and the waiter would come up and says, is there anything else I could get you? We're closing now. And it's like, you got there at 7 o'clock and it's 10:30. And it's like, whoa. And how did that happen? And that's sort of the way I felt with you. I know that I've been rattling off a lot of different topics, and you took me off topic sometimes and brought me back. But I appreciate the opportunity to reach an audience of people to hopefully help them think differently. Because our immune health, our health begins in the womb. And if we don't treat our pregnant women right, if we don't treat our fetuses and our newborn babies right, we're just digging ourselves an early grave. I know at some point our time on Earth will end, mankind's time on Earth will end, but let's not bring it on sooner than it has to. Okay.
100%, I agree on that. Thank you for coming. God bless you. God bless all your children. You have grandchildren as well?
I have 1.5.
So God bless all your family, the big family that you have.
Thank you very much.
Thank you for coming.